All right, we'll figure that out, and we'll have Dr. Radhika Natarajan join later. So without much delay, we'll start with the first topic, endothelial keratoplasty in field graft. I invite Dr. Arjun Srirampur for his presentation on EK in field graft. Dr. Arjun Srirampur has his own practice in Hyderabad. Arjun, are you there? Okay. So we'll begin with the second talk with Dr. Anubha. She will be talking on fine needle diathermy in corneal neovascularization. Welcome, Anubha. Anubha is a faculty, and she has special interest in corneal neovascularization.
This thing removed? Can we have the overview removed?
Yeah, it's full screen.
Yeah, it is already. Okay. Hi. Good morning, everyone. So I'm Anubha. I'm a faculty in the Shantilal Shangvi Cornea Institute at LVPI Hyderabad. I would be speaking about the novel and not so novel technique of fine needle diathermy for corneal neovascularization. I have actually removed the word neo from the title because fine needle diathermy does work for mature vessels as well. So the app title should be maybe fine needle diathermy for corneal vascularization. Before I jump into the surgical video, I would like everyone who's listening to just pay a little attention to the case selection, and because I feel that the surgical technique per se may not be that difficult to master, but it is important to know which case you need to do a fine needle diathermy in. So it is important to understand how important is the vessel in that condition. Do you really need to do it? And how to actually visualize the vessel, how to image it, which vessel to target, what the technique is, and whether it's a temporary solution, whether it needs any repeated interventions, and what the outcome is. So we already know how important is the vessel in relation to graft rejection and graft survival. The imaging of a corneal vessel, it varies from various techniques, like first is the slit lamp examination. That is a direct visualization of the vessel. And imaging techniques like ICG angiography, fluorescent angiography, or OCT angiography. All these are expensive techniques, and they may or may not have an importance when dealing with FND per se, but if you want to objectively quantify whether your vessel has actually receded or regressed, these do work very well in that case. But moving on to so there are several other techniques, but it is important to understand what stage of the vessel we are dealing with to actually say that whether FND would work in that case. So as you have a KYC in banking, I have actually written here KYV. It's like know your vessel. So you should understand the stage. If it is a latent phase of vascularization that we are dealing with, immune suppression helps. In an active neo-vessel stage, anti-VEGFs help. In a mature vessel stage, that is when FND comes into picture. And if it's a ghost vessel, my idea of future research can be, can you actually induce that? And ICG angiography staging is also somewhere close to what I just discussed. So the fourth stage, the mature vessel, is where you would like to do a fine needle diathermy. So there are reports, many reports. The first one was from Dr. Dua, and we have reports from SN also, where fine needle diathermy for corneal neovascularization has shown to work. So coming to our patient, at presentation, this is a 52-year-old gentleman who came to us with a herpetic stromal viral, herpetic simplex viral keratitis. It was a necrotizing stromal keratitis with a perforation. So he was initially dealt with tissue adhesive, a bandage contact lens, and an AC reformation. Went on 2 months later to look like this, where there is an adherent leukoma formation. There is, the patient is on topical immunosuppression, tacrolimus at this stage, as well as on low potency steroids and an oral antiviral prophylaxis. Just 6 months later, just on topical immune suppression, we can see that the majority of the deeper vessels which were in the center of the scar have automatically regressed. So that is one point which I want to also highlight, that there is an inflammation process which is going on in the active stage. So giving it time, maybe 2 to 3 months, on anti-inflammatory therapy, that itself, first of all, regresses majority of the vasculature. So timing of FND is important. So let us not do it in an acute stage. Let us not do it in an acute necrotic stage particularly. So 6 months later, we identify our culprit, and we think about how to deal with this particular vessel. So this is how the fine needle diathermy is done. So there is a curved 10-0 nylon, monofilament nylon suture needle. So this particular vessel is my target here. So this is the major afferent vessel. So I'm going parallel to this vessel. It is important to understand that the needle should come out also of the other side. A monopolar cautery is used at the lowest possible setting. And the there's a yellow button on the cautery needle which is pressed. And there is an instant coagulum which forms here. There is as we can see, this whitening which occurs here, so the vessel is getting ablated. This particular vessel has now been ablated from its entry point. So this is a very simple procedure actually, very easy to do, very inexpensive. How long does it last? So I actually followed this patient up on angiography. So let me move on. Yeah, so before I go there, I would like to also talk about one complication which can occur while you do a fine needle diathermy. So this particular patient only, there were two major chunks of vessels. There was one vessel which I was talking about was the main culprit. Then in the center, where there was the adherent leukoma, there was a major chunk of deeper vessels. So when you are actually targeting the tuft of deep vessels, it is advisable to go underneath those vessels. And rather than parallel, you have to go underneath. So I'll just show you what happened. So there was a major chunk here, and I go underneath with my needle. The mistake which I want to highlight here, which I think I made, and retrospectively I think, the needle end, this needle end did not come out. So, and there was an adherent leukoma, so there was a thinning in this area. So when I did a cautery in this area, there was a micro leak which happened. So just observe that. And when the needle is taken out, we can see fluid egress. So I did manage it there itself with a suturing, and later on, anyways, this patient was being planned for a penetrating keratoplasty later. He did very well. I'll be coming to the outcome as well. So there and then we managed with a suture across the microleak, and he did fine. Yeah, so coming back to the FND outcome. So this was the pre-FND vessel. Post-FND, you can see micro hemorrhages around the area which are harmless. You don't need to worry about them. They do settle with time. This is the angiography, or this is the pre-FND angiography, where you can see this prominent vessel coming in and a lot of new vessels sprouting from the main mature vessel. And this is the cross-sectional OCT image of the same. OCT-A image of the same. Then, so if you compare in the same slide, the pre and the post picture, the post picture shows that the vessel has been cut off from its bud. So it is no longer seen either clinically or on angiography. I managed to follow up this patient 3 months later itself, and I see no sprouting, but there is a micro, like there's a very small, thin tuft of vessel which is coming back here. So I would like to, this is not just one case, there are many other cases I've seen this. 3 months later, recanalization begins after FND. That is when you can think about either a retreatment or a treatment at the same time along with PK. So this patient is the one where we did the FND, and this is how he looked like at 3 months post-FND. And I went ahead and did a PKP triple for him. He did very well. He's doing fine till now. This is a day 1 picture, and the graft is clear as of now. But if you see very clearly, this vessel here is the recanalized vessel. So what I did was, at the same time, along with the PK, I gave anti-VEGF also, because this is now a new vessel which is coming in. So I gave Avastin injection subconjunctivally in this clock hour. So this is how he looks like. So I would like to end with the message from the entire presentation that FND is a technique which definitely works, but we should know our vessel before we do it. It is an inexpensive technique, can be done under topical anesthesia, quick technique, and we need to time it well. We need to understand we should not do it in an acute necrotic stage. We should avoid it in a thin cornea, and we should target the correct vessel. Multiple vessels can be targeted in the same time. That is another advantage of fine needle diathermy, and it can always be repeated. Adjuvant therapy like anti-VEGFs, or we are looking at other options like collagen cross-linking, they may have a role in this. Thank you.
Thank you, Anubha, for that very nice and clear presentation. One quick question for you. What was the cautery you had used, and what are the options available in doing this technique?
So we use the monopolar cautery that is used in oculoplasty as well. I have even tried with bipolar cautery, and it doesn't work as well. So we need to actually ablate, because we are putting the cautery, the thermal energy on the needle and letting it transmit directly. We directly, coagulating the vessel doesn't work for a long time. We need to actually occlude the entire lumen, and that way monopolar cautery is better. For this particular purpose. The important thing is to use lower setting for energy, because too much of energy can cause necrosis of the surrounding tissue. This is an already compromised cornea, so it is better to use 2 setting or just the lowest possible setting that you can for
Yeah,
this.
and you have to keep the cutting low, and it should be in coagulation mode.
Yes,
Yeah.
you're right. Yeah,
Yeah.
it should be in coagulation mode.
Yeah. Thank you, Anubha.
Many of the RF cauteries also come with a needle tip and all, so can one directly use that?
So I believe the energy has to be transmitted through something. That's how I understand it. So direct direct touch to the cornea may damage the tissue. So the point that I was actually saying about the needle coming out of the cornea, I believe when you touch the cautery to the needle actually bends a little. So it is important that the needle end is out of the cornea when we are doing that.
Right.
Yeah.
Thank you. Is Dr. Radhika Madam connected? So,
Yes, Dr. Sunita. Are you able to hear me at
yes,
all?
yes, we are able to hear you, and we know you have worked so much on corneal vascularization management, fine needle diathermy. Would you share your insights and your comments on how you perform the procedure and your recommendations?
First of all, thank you so much. It's very nice to be with all of you, even though virtually. Thanks to Dr. Sunita and Kalpa, and hi to Dr. Vanesh and Vishal over here. So I hope I'm clearly audible.
Yes, madam.
Yeah, so I first advantage speaker for bringing forth all the important points that I usually have in mind for this particular procedure. So corneal vascularization has got 3 stages. One is the inflammation which promotes the vascularization. Then you have the stage of immature vessels where the angiogenesis starts. And then you have the stage of mature vessels. The first stage steroids will help because that preempts the cause inflammation. In the second stage, it's a little bit fleeting and you can't make out very much clinically where
Thank you, madam, for joining us and for useful insights. We'll have further questions later. And now I call upon Dr. Arjun for his video presentation on EK in failed graft situation.
Good morning, everyone. So I'll be presenting a topic on endothelial keratoplasty for graft failures in complex situations. So I'll be presenting a series of 3 cases, and I apologize that I don't have a running video, so I'll be taking videos from Dr. Rishi, and I'll be explaining the procedure of DSEC. So the primary graft failure by definition is defined as a graft which doesn't clear within 2 weeks after transplantation. The incidence ranges from 0 to 5%. So there are various causes of primary graft failure, which can be because of the poor donor endothelial selection of the donor cornea, or the faulty technique of when we are preparing the graft, when the proper protection for the endothelial layer is not done, and the improper eye banking techniques like improper corneal preservation and excessive surgical manipulation or surgical trauma can also lead to primary graft failure. Secondary graft failure is defined as a graft which was initially clear, but later the graft becomes hazy and it doesn't serve the purpose. So the causes of secondary graft failure can be because of the rejection or progressive endothelial cell loss, which is expected after few years, or any ocular surface disease. So the risk factor for secondary graft failure include deep vascularization, peripheral anterior synechiae, glaucoma, or a large size graft. So management of the graft failure is we have to ascertain what is the cause of the graft failure and what is the chances of success after the surgery, and we have to measure, ensure that the whatever regraft we have done has to sustain for a longer period of time. So when we are trying to make a decision whether to go for a regraft in the form of penetrating keratoplasty or doing an EK in the form of DSEC or DMEC, we have to see for the any surface scarring is there. If there is significant scarring, especially in the visual axis, then endothelial keratoplasty will not work. We have to resort to a penetrating full thickness corneal transplantation. Or if there is associated ocular surface disease, then we have to again go for a full thickness PK. If there is no ocular surface disease and there is less risk of immunological graft rejection, we can go for endothelial keratoplasty in the form of DSEC or DMEC. So this is when we are considering doing a DSEC for a failed penetrating keratoplasty, few things which we have to look into is the scarring. So that can be seen clinically on the slit lamp, or you can also perform an anterior segment OCT. If the scarring is significant and especially it's in the visual axis, then it is better to go for a full thickness PK because it's not going to give a good visual acuity to the patient. If the scarring is paracentral or in the periphery, you can still go for an endothelial keratoplasty. And if there is a significant astigmatism after a full thickness failed PK, after all the sutures are removed, again, if you do an endothelial keratoplasty, the patient will end up having still that astigmatism. So in those cases, it's again better to go for a repeat PK. If there are deep vascularization, again, that is a risk for a full thickness penetrating keratoplasty. Still, in those cases, if the vascularization is deep or in the superficial layer, you can still go for a DSEC. And where you are trying to do a DSEC in a failed PK, when we score the DM, so we have to make sure that the scoring has to be lesser than the size of the previous penetrating keratoplasty graft. Suppose if the PK graft was 8 millimeters, so we have to reduce by 0.25 or 0.5 when we are scoring the underlying Descemet's membrane. Because if you extend the graft-host junction, there is a chance that the graft-host junction may open up. And in some cases, there is no need to score the Descemet's membrane, that is called NDSEC. That procedure is called NDSEC, or non-Descemet stripping endothelial keratoplasty. And in certain cases, the attachment becomes a problem. Even after a full thickness air tamponade, the graft may not attach. So in those cases, we need to put peripheral vents in the paracentral area of the graft so that whatever fluid which is trapped within the interface will come out, and that will help in the attachment of the graft. So this is one case of a failed penetrating keratoplasty. The surgery was done 5-6 years back. Then the patient had a central corneal edema. This patient, I did a DSEC. So here you can see in the slit section, the anterior most layer is a and the graft unfolding and attachment of the graft becomes a problem. So this is a day one post-op photo showing an air bubble within the anterior chamber, and you can see immediately on day one itself the the cornea starts clearing up. And if there is a failed DSEC, so you can go for a repeat DSEC also. So the left side photograph shows a graft DSEC which was done, and this DSEC failed. So in these cases, you can just go in and pull out the old DSEC graft and you can put a new DSEC graft. So there's no need for scoring the Descemet's membrane because it's already scored. And the size of the DSEC graft, you can size it according to the white to white. So there's no need to measure the sizing of the DSEC graft is not that important in these cases. So the left photograph shows a DSEC failed graft, and the right photograph shows immediate post-op photo showing air bubble in the AC and a new DSEC graft which is there attached nicely. And this is one case which I did a long time back, where DMEC was done under a failed DSEC. So in this, normally what we do is, if the DSEC is failed and you're going for a repeat EK, so we pull out the old DSEC graft. But in this case, I did not pull out the old DSEC graft. I retained the DSEC graft, and under that, I attached a DMEC graft. So this patient was a 54-year-old female, and history of DSEC 5 years. She underwent DSEC 5 years back elsewhere. At presentation, the visual acuity was CF. And in the center of the cornea, you can see a lot of bullae, which suggests the graft failure. And there was a large peripheral anterior synechiae at around 5 to 4 o'clock position, which was attached to the old DSEC graft. And this is an anterior segment OCT showing a thick edematous cornea and underlying DSEC graft which was failed. And you can see a hypertrophied epithelium which was over the cornea. So in this case, the options were doing a repeat PK or doing a repeat DSEC, or explant the old DSEC graft and put a new DMEC graft. Whereas because this patient had a large peripheral anterior synechiae, I thought if we try to pull out the old DSEC graft, the peripheral anterior synechiae might open up and there can be iridodialysis or bleeding and subsequent problems on table. So I just retained the old DSEC graft, did not remove the
through a complex surgery. And believe it or not, Google also finds that to anticipate, to plan, to analyze, and then to implement. So the first message here would be that surgery is done with the mind and not with the hand. And dexterity is not the most important critical thing. It's actually overrated. So what is more important is intelligence, knowledge, creativity, and the courage to stand up again once you have complication, and don't lose faith in yourself, and perseverance to keep moving on. These are things which are not so stressed upon. Dexterity is something which is stressed upon a lot. Now, of course, the most critical aspect which we are not taught is to develop a good surgical judgment. And for all this, to develop, you need to train the mind, which is probably the most important thing to do. So not the hand, mind is the key thing here. So in the next discussion would be, can we make surgeons, or if they're just born, whether you have it or you don't have it? So this is a typical graph, for any skill to take. If you say 100 surgeons of here, there's no doubt in my mind that 3% of them are extraordinary. They're blessed. There's something which is, they're extremely intelligent. They have superb vision, maybe great stereopsis, 3D, 4D, and maybe some super stable hands as well. And the second part of the 3% are poor. The problem is with the attitude. They don't have any intention or motivation to learn surgery. And believe me, none of the second 3% are here in the hall. So let's not talk about this. So let's talk about the 94% of us who are the average, who are fairly competent. I confess that I belong to this 94% of the segment, an average surgeon. The question is, can we, squeeze in these average people into the top 10% of the people of the top performing surgery? And I believe it can be done if one can develop the right attitude and, of course, a little bit of a guidance. So this is a typical learning curve of any skill, including surgical skill. So initially you begin by being extremely clueless, and then you're naively confident, but you don't know really what you know and what you don't know. Then discouragingly realistic, you have an idea like, okay, realism strikes to you and you know how bad you are. And when you know this, how bad you are, actually the learning starts from there. And this is the graph, typical graph, wherein you develop from a novice to an expert. And actually, over a period of time, you become from an advanced beginner to proficient, and ultimately, over a period of time, develop expertise. But what actually changes over this entire course is one thing, that is your ability to take decisions appropriately. And that is what becomes seamless over a period of time. So this is a typical journey of mastery, and you will have lots and ups and downs. And obviously, you have a situation where there is a step of, where you, from proficiency to mastery, there's a lot of complacency which develops in. And this is the most common reason for us of reaching to that the last step here. So learning curve, as I told, to begin with, we are unconscious about our incompetence. Then you become conscious of our incompetence, and that is really, the bad day for us, really know. But that actually the learning starts from there. The common question which I always asked is, how much long does it journey to become from a novice to expert? Well, actually the answer is, it depends, and depends on only one person, that's the surgeon himself. So I just go and see in your mirror, that's what the answer lies in. The answer lies within himself. So it depends upon the passion and the focus which you have to develop it. Now the question for teachers who are here or the trainees is, can we accelerate this learning curve? Can we make it much more smoother? So learning surgical skills, I would like to divide into 3 aspects. The first is the dexterity aspect. Second would be the definitely surgical secrets which need to be passed on to the next generation. And the third is the decision-making aspect of it. Again, this requires a little bit of mentoring. Now, let me begin with the motor skills part of it. There's no secret in this. You just have to sit and practice, and it is variable. Some surgeon masters the skill in 10 hours, somebody might not do it even in 100 hours. The practice is the only skill here. Regarding the decision-making aspect, this is where the mentoring aspect comes into picture. So, a lot of hand-holding for the younger surgeon is extremely critical. Now, the decision-making in crisis situation is extremely complex. Even the most experienced surgeons, because the mind is so clouded at that crisis situation, you don't take appropriate decisions. So the best strategy here would be to teach our students to have game plan ready, plan A, plan B ready when the crisis strikes. We don't want the Abhimanyu syndrome, you're caught somewhere and you don't know how to come out of it. So if you have a plan ready, like a protocol ready for every conceivable complication, even the first complication that young surgeon is going to have, then things, believe me, are going to be much more easier to handle. Just for an example, I'm telling you, examine the first nucleus drop a person is going to have. See, this is an inevitable complication, and I believe that it's just a matter of time. Apna time aayega. So always, how do you prepare our young surgeons to deal with this? I think divide them into 2 aspects. One would be intraoperative strategies. Next, how would you deal with the patient? If you're well prepared to handle these scenarios, things will be very clear. So the first thing is intraoperative side. Don't think about the future, how you're dealing with the patient. At that point, be sure that don't go fishing over the nucleus. You want to keep the cornea clear for the vitreoretinal friend to see and help you out at the later stage. Close the case early, do anti-vitrectomy, and then deciding on your surgeon's vitreoretinal preference, whether to go and put an IOL or not. Very clear-cut idea. And then next would be, how would you phrase your words when you're dealing with the patients? So I would teach my students like this, use phrases like, don't frighten them. The cataract could not be removed, that's a fact. The cataract surgery could not be completed because I couldn't have access to it. It's in a deeper place, I can't have access. Don't worry, I have my friend who specializes in this area and he can do the job for you. Most importantly, you arrange the logistics for the patient and just ensure that it is taken care by your VR friend. If this clarity of thought is there in you when you have the complication, it's almost certain that you don't end up in creating a worse situation than what it is. And these are things which needs to be tutored. Now coming to the surgical secrets, I think this is what makes a lot of difference in the way we teach our students. The traditional approach has been always like, you do the surgery, the observer is seeing on the monitor, and you expect the student to learn everything by itself. And believe me, it's not difficult. 90% of the people don't get it. It is like, a Japanese film is going on without subtitles, and you're expecting to just learn on yourself. I learned it by that way, and you're expected to learn like this itself. So all are not sharp enough. 90% of them don't get enough what the surgeon is doing. Why is he holding the instrument just like that? They just don't get it. So it just delays the entire progress. So if you can share the secret to the student at the early stage, the learning curve can be enormously fastened, I should say. So what I learned late in my surgical career, simple things, just like using your second hand to stabilize the globe, even by doing your incision creation, how can you automatically hold the globe? These are very, very simple things which it took at least 3-4 years for me to understand. Just stabilizing the globe is such an important aspect of every part of your surgery. While doing your access, just use a second instrument in such a way that the eye is well centered. The other important thing which I learned late is ensuring that the position of the eye is always looking straight up. And to ensure that your chin and the forehead has to be at the same level. Difficult to see through the grave, but if you can achieve this, always have the center looking eye up. So these are very, very small things which a beginner surgeon, even me, I took it a long time for me to realize. The value of different OVDs, as Indian surgeons, we really don't teach these things to our students, There's nothing more expensive than your vitreous and retina or the cornea than any of the OVDs. So we don't discuss much about the value of these different OVDs, especially in complex scenarios like PC tears, polar cataracts, intermittent cataract. They can be lifesavers. And if you can teach them, the surgery becomes much more simpler, faster, and easier. The outcomes are definitely much more better. Now, just to share one thing which we would like every you have a PCR, do an antravitrectomy, you want to implant a multi-piece lens in the sulcus. Now, using sodium hyaluronate inside the ciliary sulcus ensures that you maintain space there. The haptic does not go into the bag instead of the sulcus. And this is the role of the OVD, specialized OVD. Just enlarging the incision a little bit ensures that you don't struggle to put in your 2.8 millimeter cartridge inside. Because the eye is soft, going in through itself becomes a challenge. These are small nuances which, if the surgeon picks up, even the first PC tear can be managed well. Now, doing removal of this OVD with the OVD still inside, with the post-vitrectomized eye, if you keep a bottle head which is very high, the chances that the lens can get dislocated and go back into the vitreous. These are all small nuances which, if the trainee surgeon has been taught, he can manage the first PC tear as well good enough. But these things, these needs to be shared and, with the younger surgeons so that the learning curve is much more faster. And we believe that most of the complications, some of the complications are preventable, not preventable, but I think most errors are unforced. I would like to classify them, the unforced errors, into two aspects here. One would be you're not ignorant about the skill-based, and the second is they're not skill-based purely because of poor decision-making at that particular situation. So let me go back and show you one scenario way back in 2011. So a typical scenario of, you are taught that, you have to maintain a deep chamber to do rhexis, especially in these cases of intermittent cataract. So coming out and trying to inject OVD into the eye here. And look, I'm trying to pressurize the eye, and it just goes off, okay? So these are some basic things, wrong way of injecting OVD, which it took some time for me to just realize and aspect. It's just a position of the cannula is not right enough. So when you try to inject OVD in an open capsule in the central area, obviously the pressure is going to build up in the intercapsular region and then go. The right way to inject OVD, always in an open capsule, is always try to place it in the peripheral part of the chamber so that you don't increase the intracapsular pressure which you intended to. So these are small little tricks which you learn over a period of time, but if you can teach them from the first day itself, these unforced errors can all be minimized. This next, the scenario 2. It's a routine case posted for phacoemulsification. Rhexis I've just stopped. It's probably the 5th or 6th case in the list, and suddenly, it happens, okay? This is highly avoidable. Simple thing was this patient was a patient who had compromised hearing. He just reacted to some noise, and he thought he was asking him, and just moved his head. This is purely, it is nothing skill-based here. It is surgeon lacked the awareness of the situation. So poor decision-making was the culprit here, not the skill here. This patient was just not ideal for topical phaco. So being aware of the situation, these are all small issues which lead us to many other things, bigger problems. So unforced errors, as skill-based and non-skill-based, and our duty is, the non-skill-based aspect of the surgery, which is what we don't transfer. The younger surgeons are so enthused about, learning the finer details. We forget about teaching these things. The non-skill basis, these are all poor decision-making, lack of situational awareness, and poor concentration. It's all depends upon one thing, and that is really in the mind. The focus should be for us to training the mind, and this is something which we need to transfer to our younger colleagues. A message to my younger colleagues here, from day one of your practice, if you can invest and record and see your own surgeries, you can be your best teacher. There's no secret about it. So you have to be brutally honest in analyzing your own surgeries. And if you're not ashamed to seeing your own surgery, the first step is that. Then you can know that, you can show the surgery to other people and then to the world. So start recording your surgery and be brutally honest with your own surgical things. Things are different now than what 20 years back, okay? For one tip, we had to travel to a conference in a national or state conference to get one surgical tip. Nowadays, the surgeons are blessed. Information is available 24/7 at your fingertips. What you do with the information is up to you. So the message here I would like to conclude by saying is that surgery can be learned and taught. It's not something you're just born out with it. A few people, there are exceptions, definitely, but definitely, a little effort from the teacher and a lot of effort from the student ensures that your learning curve is extremely smooth and it need not be so long. But there are few things which a teacher needs to develop, and this is something which is not recognized and teachers are not acknowledged for that. The teacher obviously has to be passionate about things. The most important thing is the patience. There's nothing more frustrating for an experienced surgeon to sit there and see a young surgeon operate. There's nothing more frustrating than this. So patience is probably the greatest skill a teacher has to have if you're doing a hands-on training. And obviously, above all, you need to be selfless and generous to share the small tips on wisdom which you have developed over a period of many years. And for the trainee, I think these are the 7 commandments which are extremely critical. The most important, attitude. The attitude is probably the most important thing. Patient first, that should be the criteria. If you can put the patient ahead of anything else, most of the decision-making in your surgical career, whether you're experienced or non-experienced, it just gets simplified so much. Whether the equipment which you want to buy, whether you want to refer a case to your colleague, everything is just settled if you have the right attitude toward patients first and be grateful to the people whom you have learned it from. Obviously, excellence. You just have to pursue excellence and just follows. Believe that, great surgical hands is just a myth. Each one of us can become competent surgeons if you have the right attitude and the motivation and focus. Be knowledgeable. Get the basics right. Try to focus on smaller things. Am I seeing well? Am I in control of the situation of the surgery here? These small things are the things which you need to learn from your masters rather than how to hold the instrument. Periodic self-assessment and critical thinking. There's nothing more important than this. You can't be complacent. You have to be brutally honest in the way you analyze your own surgeries. And no matter what stage of the career you are, if you can go back and see your surgical video of that day, I'm sure you'll find 100 ways of improving that one particular step, always. And the last important thing is, never consider yourself an expert. The day you start doing it, that's the day your downfall is guaranteed. I think with that, I'd like to say thank you for this honor and opportunity, and thank you for attention.
Thank you, Dr. Megur. Excellent message. It's very encouraging to even budding ophthalmologist and even some of the ophthalmologists who was practicing. Yeah, Please come for the one medal, sir.
I think that was an excellent talk, and the message was very clear that surgery is like any other skill can be learned, and a good surgeon is not the one who does not make any complication. A good surgeon is the one who comes out of it without causing much damage. So that's what you told very
He visited many schools to screen visual defects in children. He tried to educate the farmers on leadership practice and how to avoid professional hazards. He rendered voluntary education services to schools. His service united
We invite Dr. Srinivas Reddy to deliver the Dr. Hari Kishan oration.
Good morning and my cordial namaskars to everybody. I am very grateful to the organizers for giving me the opportunity of sharing my 42 years of rural practice experiences and 6.5 years postgraduate teaching experience. This opportunity will definitely enhance my enthusiasm to work more in future for the sake of postgraduates academically. Regarding any profession, it has three important dimensions. That is one, acquiring knowledge and skills, then competence needed to succeed in the profession. Third and most important thing is core values for the right use of the above. That is ethics, following ethics in any profession. Regarding our profession, there are three important things regarding the professional ethics. That is one, responsibility feeling, bring credit to the profession by following ethics. learn by updating, and share your knowledge to the others by teaching. So in this figure, there is the Dharma Chakra. So this is a symbol of dynamism. Its 24 spokes represent 24 virtues to follow in any profession. So at the bottom of the Dharma Chakra, there is one verse taken from the Bhagavad Gita, Yoga Karma Sukaushalam. That means doing work skillfully is yoga. That means work is worship. So as far as ophthalmology is concerned, it's by definition, it is a branch of medicine and surgery from which it cannot be separated, because so many systemic diseases are reflected in our eye. Sometimes we detect first the systemic diseases before the surgeon or physician. A great saying in our Indian scriptures that Sarvendriyanam Nayanam Pradhanam. It supreme to all organs of our body, because without eyes the life is dark. So our main duty is to save eyes of the people and prevent the burden blindness to the society. So my two fields of, in my practice, the chief important fields are comprehensive ophthalmology and the community ophthalmology. I give more importance to these two things in my practice. Regarding my post-graduation, I utilized my post-graduation period maximum and worked very hard. Daily I was working. This is for the inspiration of postgraduates, what I am saying. I worked nearly for 8 to 10 hours a day in referring 20 standard textbooks of ophthalmology, and I wrote notes from all those 20 textbooks. And out of those 20, 15 volumes are System of Ophthalmology by Duke Elder. So even that was responsible for my appreciation for my examiners in the final exam. And now these pages are useful to postgraduates now also. Now this has become a great stimulus for me to teach postgraduates. So after completing my post-graduation, straight away I went to Jammikonta, a remote place. I willfully opted a remote place to serve the periphery people. Initially, we had so many difficulties to establish, especially for the surgery. When we came out of post-graduation, we were trained only intracapsular extraction of the cataract, that too without any corneoscleral suture. So we had a lot of complication initially. Then we had to face so many things. Somehow we faced and rectified by attending CMEs and workshops. We learned the suturing techniques, extracapsular extraction, followed by IOL surgeries. So in my practice, two things which I follow ethically. I am far away from RMPs. I never entertain RMPs. From the last 43 years, I did not entertain any RMPs, and I am far away from kickbacks. Instead, I pass on the benefit to the patients only in the form of discounts from the diagnostics. So during my practice, school, I visited so many schools to screen the visual defects. I was making the people, mainly students, making aware of the sequelae of the visual defects like amblyopia and squints. Then I was participating in many health camps, and I was awareing the public on mainly on the health tips, and especially I was always educating them what are the menace of quackery and what happens when they go to the quacks first. So because I was doing this because lot of patients, first they go to the RMPs, get the condition worsened and come to us later. So with photographs, proof, I used to post all these disadvantages of quackery in the papers, and I was giving a wide publicity against quackery. The main professional hazards, the victim of the patient, bulk of victims of the patients coming to are from farmers and industrial workers. Because I am a farmer's son, I have special concern with the farmers, for the farmers. So a proud moment in 2017, when I received nearly 300 patients of ocular toxicity with pesticide poisoning, pesticide spray, while they are spraying in the fields of agriculture. So when I got 80 patients in a span of 1 week, I thought of doing something to get down the number of cases and prevent the toxic effects. I wanted to educate the farmers. Immediately I called for the press meet and took the help of agricultural department. So they are demonstrating how to wear the PPE kit and how to prevent the toxic corneal toxicity and even general toxicity also. And I was writing so many articles on paper. I utilized the media to the maximum to give wide publicity for prevention of things. In one thing, I had a poster exhibiting in my clinic also how to prevent toxic things while spraying the care taking while spraying the pesticides. To my because of my efforts, I could bring down 300 victims last month to less than 30 victims next month. So that gave immense satisfaction as a farmer's son. Next is industrial workers. Majority people come with one more thing for the farmers is the calotropis toxicity. I also was educating liberally while dealing with the farms to avoid the calotropis toxicity. Second, the industrial workers, majority come with the foreign bodies, that to some central foreign bodies, they come late, get infected, or they try for themselves with unhygienic method, or they go to the RMP who tries with a unsterile cotton wool, they rub it like anything and damage the cornea. Lastly, they come to us. So I always show these photographs to the industrial workers. I insist on preventive measures and PPE kits while working. So I always explain them how they can go blind by these central FBs. Even after removal of the metallic foreign bodies also they can go blind. The visual difficulties will be there, and I was insisting. See, in these photos there are two sidrosis bulbi, and that there's multiple foreign bodies that last top. So that fellow went blind in spite of so many warnings. He got so many foreign bodies and he got blind. So as a social responsibility, I gave a PowerPoint presentation to the drivers in the RTC department. Once they were conducting training classes for the drivers, they called me. I gave a PowerPoint presentation on the visual needs of the safe driving. So I was explaining how the vision will be in the case of cataracts, in the case of glaucoma, in the diabetic retinopathy, in maculopathies, how the vision, they have defective vision, how that affects the driving. And ultimately, I was reminding them the morality and the ethics of the profession for they advising avoiding alcohol consumption and mobile watching while driving for the safety of the passengers. Next is I participated in many high donation campaigns, especially school children and even society things also. So stressing upon the need of the eye donations to motivate them more, I myself registered for the eye donation and even my body after my death. So even that I was exhibiting my certificates in my lounge, clinic patients lounge to motivate my public coming to my hospital. Even doctor has donated those things. Why can't we? So the main intention was that. So my passion for education made me to render my voluntary services to the educational institutes, Shishu Mandirs, that is run by Saraswati Vidyapeetham in Telangana state. And there I learned educational psychology and principles of teaching and learning. Even these principles are now becoming useful to me for the postgraduate teaching now. So after recognition of these things, our Telangana state offered me a scroll of honor on the Doctor's Day in 2019. So a special mention about the white coats. Whatever case I was discussing with the postgraduates, all the cases I used to post even to white coats also. Like that for the last 6.5 years of my teaching, so 1,300 and clinically important cases I uploaded and presented to the white coats. And this white coat with my profile containing 1,300 cases, now he has become a very good teaching tool for my postgraduate teaching. So because of my high number of cases posting in the white coats, I received 11 times championship award, my top contribution academically. So regarding teaching learning process, simple one-way lecture is a very least beneficial, only audio-visual discussions and practically seeing has maximal effect. I have donated my 25 years of AIS journals to postgraduate library of Pratima Medical College, Karimnagar. So this side, I wrote an index of the posts I sent to the white coats. Because of this, I can retrieve any case which is posted earlier in the white coats. Whenever the post-graduations need a case discussion, I retrieve all similar such cases from that, and I discuss all things together so that they will have a wide clinical exposure of. Then this was my teaching. Starting teaching was encouraged by many friends and teachers of medical colleges, and especially my notes was the main stimulant to me, and the educational tool of education is the white coats. Regarding education, what we think is teachers, they give lecture, something we hear it, we go out. So we will hear from this and we lose it by, leave it by other ear. So that is not the, education is a bilateral process by which a teacher and a student interact each other and they are influencing each other. That is the way of education. In the teacher is the donor and the student is the recipient. In this, the donor being the teacher, he should be highly knowledgeable and devoted towards his profession on one side. Other side, a sincere and honest student, a knowledge sucker, thirst of knowledge should be on the other side. And the third thing in between them is a good teaching learning environment. That is a relation through a good teacher-pupil relation must be there for a fruitful education and teaching learning process. So the best teacher, what we say is, the teacher, one who imposes whatever he knows, is not the good teacher. The teacher who inspires the student, they should learn their own. He has to guide and inspire the students. He is the best teacher. About the students who is ready to learn. You should readiness to learn, show interest, and he should be a sucker of knowledge from the teacher instantaneously, as our teacher is saying at a teaching. The most important thing for the in the teaching and learning process, the role of question. See, in Bhagavad Gita, there is a verse, the meaning of which is, you serve your teacher. You repeatedly ask your questions to your teacher. The knowledge learned through these methods is the supreme knowledge. But unfortunately, I found in many schools and colleges, they are reluctant for the questions being asked. So they are afraid of answering to the teacher's question, because probably by the imaginary fear of going wrong or feeling what the others may think. But that is not the correct way. You interact with your teachers, you answer to the questions of the teachers, and you yourself ask the questions to the teachers and acquire knowledge through the question. Is a thought-provoking one, and it leads to a semantic memory, and that causes to remember the things for a longer time. Next, not moving, next. Stuck up అయింది. The best teacher is the one who introspects himself regularly. He has to self-evaluate and he has to think whether I am justifying properly the teaching and making the students wise. This is the introspection. This leads him, and by updating everything, every time he has to update and assess himself to what extent he is justifying the teaching to the students. So this is the self-improvement, professional self-improvement of the teachers. So my journey of postgraduate teaching started with regional hospital students first, then next is Pratima Institute of Medical College, then Karimnagar. After that, slowly numbers increased. Now I am dealing with the 10 medical college postgraduates online. So I always ask them to first you concentrate on the basics. Then you can go to any specialty, subspecialty level, and you methodically to examine and have a group discussions, ask questions and answer to the questions of the teacher. These are my assertions to them. So have a comprehension of the knowledge, and community ophthalmology also they should never forget. Wherever needed, it has to be implemented. So in my teaching, I follow two important things. Comprehension is one thing. Discussion of similarly looking things, by differential diagnosis, I try to convey much knowledge to the postgraduates and to have a wide clinical exposure. See, these are group of photos taken at different times and loaded and saved in my white codes. Whenever I see one case, similar looking cases, I retrieve from them and keep at one place and have discussion with comparison. So I think this will make them learn more and more conditions, and they will have memory in their memory for longer and longer time. So these are the notes, tips, methodical and sequential examination of a case taking, of ophthalmic case taking. So whenever you get a case, you hear this, you listen and ask the questions and symptoms and history. First, you have to go for the relevant systemic examination, and then you come to the local exam. In local examination also, what the students have the habit of get tempted to seeing by one prominent or two prominent signs, immediately they commit diagnosis. That is not correct thing. You start seeing from face examination, and then lid palpebral fissure, then comes the lid deformities, then comes the lacrimal versus non-lacrimal swelling. How do you differentiate between them? Then comes the orbit and globe, ocular deviations, paralytic ocular movements, then conjunctival, variety of conjunctival congestions from various causes, and variety causes corneal edema cases, and limbal lesion. They all look together, but they have to differentiate what is what. So even corneal disease is looking similarly. Then comes the anterior chamber. There are so many varieties of hyphemas from different causes, hypopians, pseudo-hypopians from different causes. I exhibit all similar cases at one place and discuss together. Next comes the uveitis in unoperated eye, and how pupils in operated uveitis cases in operated eye. Then all white pupils, it's just simply iris shadow, how by iris shadow you can differentiate so many white pupils, where it is located, the distance between iris and the distance of the opacity, simple by iris shadow you can assess. Then lens, so many lens pathologies, dislocations. There are so many, these are conditions, lens rupture and differential diagnosis, looking similarly the other conditions, and so many lens-induced secondary glaucomas all look together, how the hypopian anterior, posterior dislocations, burst Morgagnian, leaking Morgagnian. See, even there is a curled up capsular lens capsule curled up in the anterior chamber. So these we have taken a view of this sample of stepwise examination. My message to the beginners is there is no shortcut to the success. To be remembered ever, there is no substitute for the hard work. See, this figure gives you, even though the animal lion is an animal king, it has strive hard for its food. So also you take the example of ant. So it's a discipline and hard work will tell you how to work. These are the nature's lessons what we learn. So the eagle, though it is so powerful and they can fly thousands of kilometers very fast, suppose if it is lazy, it will remain where it is. So you be positive and do the best whatever you have in your hand, do the best wherever you are. Don't look for the, immediately look for things which you don't have, but slowly improve and be positive in your efforts. The ultimate, the concluding message is we have targets. As ophthalmologists, we have one target. As human beings, we have another target. As ophthalmologist is only prevention of blindness. We all do diagnosis and treatment modalities are only intended for the prevention of blindness and reducing the blindness burden to the society. As human beings, dharma is the only goal for us, and by dharma means ethical living and truthful living. We are humans first and doctors next. So we have to follow dharma even in our lives and in our professions. The last slide is, I truly believe in ethical things. So many, our Indian holy scriptures say so many ethical things. After this, I quote two things and I finish. Paropakaram idam shariram. Our body is meant to help others. One more beautiful quote which I believe is, don't go to your grave with your best work inside you. Try to die empty. Before you die, you transfer or share all your good things in you with the societies. You die empty. Don't die with full of your good work inside you without distributing to the others. So with that intention only, I donated my eyes. Even I donated my body to my parent medical college, Kakatiya Medical College. So these are things. Lastly, I had to thank postgraduates, past and present postgraduates, just because of the interest they showed, and I could continue my teaching for the last 6.5 years. Just because of my teaching only, I got recognition. First, I have got an opportunity as the orator just because of the PGs. PGs are my heroes. So I dedicate my talk of today to my postgraduates. So if chair permits, I request to call my postgraduates present first while I am taking my sheet, sir.
Yeah, thank you, sir. We will call them, okay, because sir, it is an
Thank you, sir.
Harikishan Gorintala oration. Would you talk something
Yes,
about the Harikishan, sir? And what?
Dr. Harikishan is first my classmate from MBBS. He is my best friend. He is very determined and he established a big nursing home in Karimnagar, and he does a lot of things now, in no way inferior to any corporate hospitals or teaching institutes he runs. So I am fortunate to receive his oration from my own friend and my classmate. Thank you.
Classmates.
So my request of post-graduation students, sir, to call.
Call your postgraduates. You have any postgraduates?
I request all my present and postgraduate students to come out to the dais, even present senior residents also. Whoever present here, please come.
From Pratima, sir? From Pratima Medical College?
All colleges.
All college, okay.
Whoever, all students.
So all postgraduates, SRs, please come over the dais.
Please come, sir.
Come, sir. No postgraduates in this hall? No, please come.
you, sir. That was a very inspiring and moving oration. In spite of staying in a small town, you are spreading the message of knowledge to all. And the last message, I think, was the best, that you should go to your cremation or grave empty. Give away everything. Dr. Deepak Meghur, who was the recipient of the previous oration, was not present during the inauguration. So as Chairman Scientific Committee, it is my duty to have our President and Secretary hand over the medal, oration medal to, right now. I request our President, Dr. Badrinarayana, to hand over the oration medal to Dr. Deepak Meghur for the Ravi Kumar Reddy Oration 2023. The past president, Dr. Ashish Bansal, will hand over the plaque for the same. There were some other awards also which were not given because the recipient was missing. Dr. Arvind Maurya was the recipient of the Swaroop Video Competitive Medal. And as Swaroop, can I hand over this? Thank you.
Thank you.
Without further ado, we'll hand over to the next interesting session of Ophthalmic Premier League. We have two excellent anchors, Dr. Srinivas Joshi and Akshay Nair. I'm sure they'll give you a good entertaining time along with a lot of interesting videos which will not just entertain you but also you'll learn a lot from them.
Morning. So we are going to start Drishti Ophthalmic Premier League 2023. I request all the team captains, please come forward. I request Dr. Akshay.
So do we have all the team captains? We have 4 amazing teams. The Karimnagar Kings, the Hyderabad Hustlers, Warangal Warriors and the Nizamabad Nawabs.
So I request the team captains, if they are there, to please come over. I can see Dr. Gopal Raju sir here, Dr. Arvind Maurya, Dr. Somshila Murthy
and Dr. Santosh Unal.
And Dr. Santosh Unal.
All in costumes, perfect, excellent. So we have our Karimnagar King Captain Dr. Arvind Kumar Maurya here. Hustler, Dr. Somshila Madam. Hyderabad Hustler
Dr. Siddharth Dikshit, Dr. Vineet, Dr. Praveen. Yeah.
Excellent.
So Dr. Siddharth will be representing Nizamabad Nawabs. 3 cheers of claps to all our 4 teams. Okay, so let's go into the intro video first. I request all the team captains so that the audience will have a view of the intro video. Can we have the video on the screen, please? Lights off. Wait. Sir, wait, we have to take it off. Please play. Lights off. Sound. 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 Sound, please. Yes. Okay, so that comes the intro video. Now we have a brief introduction with all our teams here. Can we have the audio, please? Lights off. Okay. Thank you very much.
Can we have a round of applause?
captains are fighting here. They are not agreeing. So it's taking little time. Please, sorry for the inconvenience. Everybody wants to present at the last. So they are undermining the intelligence of the judges. Sir, we have chosen such a fantastic panel that the first presenter till the last presenter, they will have equal amount of enthusiasm and equal amount of energy. So don't worry, sir. I request our honorable judges to please come up on the dais, please. Our honorable judges, we have Dr. Raja, sir. Music. And then we have Dr. Sudhakar Reddy, sir. Music, please. Dr. Badri Narayan, sir. Dr. Rajlingam, sir. So we have all the 4 judges here, and now we are going for a toss or the chit. So Karimnagar Kings goes last. Warangal Warriors go first. Hyderabad Hustlers go second. Nizamabad Nawabs goes the third. So, once again, Gopal Raju sir, the judges are here. You are disrespecting the judges by walking in front of them. So you have to take a back step, sir, not showing your back. So anything you want to give it to the judges? Some crypto or something? Huh? You want to give? Dr. Arvind wants to give something to the judges. Dr. Arvind, the oral promise is self-sufficient. Yes, madam, you want to give something to the judges?
Just that I'm all esteemed judges. I'm sure you'll recognize who are truly scientific and talented, which is us, Hyderabad. Remember, this is Hyderabad city, Hyderabad Hustlers.
Anything you want to give the compeers, madam? The people hosting the show, anything you want to give them?
These are my best buddies. I've known them from their childhood. So, I mean, I'm sure that they
Madam,
do
oral
good.
promises won't work, madam. This is a real politics which is being played
All
here.
the prize money will be equally distributed.
But there is no prize money at all. That's why he makes this intelligent answer. There is only the trophies here. So the judges?
I just wanted to know about the team selection. What was the option? Who was selected? What is the base price of the players? Can the captain say anything about how did you go about what was the basis on which you did you fix the players or was it?
No, this was done by Rishi. I think I haven't influenced Rishi. I haven't influenced anyone. Yeah, my team is a composition of all specialists, all top class teachers.
You have best batsman and bowler, no all rounders.
Yes, we have best opener, best striker, best pacer.
But no all-rounders.
No all-rounders.
We go to the Dr. Somshila, madam, please.
This is a very weak response. In my team, we have powerful women, best women, and all-rounders as well. And each has a specialist. So we have right from anterior to posterior segment and osteoplasty. It's very, very, very confident. And the most beautiful.
We are all looking forward to Hyderabad Hustlers, the men versus the women.
Yes, Nizamabad Nawabs.
We have the blessings of the women and an impact substitute right in the beginning.
But the judges are not women here. We have to please the judges, boss.
With their blessings, we will.
I think Siddharth, your captain may be unhappy by your opening statement. You said that the money will be distributed among all the teams. That's a loser's talk, basically. You think you are going to win?
Sir, mental disintegration other teams have to do. Judges don't have to do.
No, I said your captain may be unhappy.
Captain was okay. Thank you very much. Please take your seats. I request judges to please take their seats. So as you know, it's 4 minutes each presentation. So each team will have 18 minutes, 2 minutes for the intro video and 2 minutes for the technical difficulties. So no extra time given for any technical difficulties. So I request you have at one laptop, or you can have the two laptops here, two presenters this side and two presenters this side, so that there will be no confusion. So 18 minutes is the very strict time, 4 minutes per video, per presenter, and after 18 minutes, if any audience wants to make a comment or any other person wants to make a comment, then it will be only after that. But in between that, audience has the full choice, full rights to drag them to the floor. So you have all the rights to drag them to the floor, but not the other contestant. Other contestant will have the rights only after the completion of their team presentation. So audience are the real Praja and the Rajas here. So he is bribing me.
I got 2 envelopes.
With a blank paper, not even check. Very bad, Dr. Modi. It's 18 minutes per presentation, per team. So each presenter will present only for 4 minutes. So 18 minutes per team. And once the one team goes on, all their 4 people have to present it. Okay? So let's start the OPL, Drishti OPL 2023. So I request the honorable judges. It's based on the best scientific video and the best entertaining video, runner-up scientific video, runner-up entertaining video, and the best team and the runner-up team. And we have introduced special prize this time is for the best dressed costume, runner-up and the winner for the best costume. Okay, so shall we start? I request the first team to please come up on the dais. Dr. Gopal Raju sir, let's go with your captain. You have the intro video as well.
Heavy.
So I request all the team members to please come up.
So all the 4 team members can come up here and we'll present one after the other.
Dr. Kavya Chandran, Dr. Rachita, Dr. Deepak Megur.
Presentation. Own laptop. We'll swap, we'll present from that side.
Own laptop this side. Others laptop that side.
Our laptop.
Our laptop.
So what is the order in your team? Who's going first?
I think Dr. Kavya will be going first.
I think. So you're not sure, sir, still?
No, it's a secret.
God only knows your secret.
And they have let women go first, ladies first.
Okay.
First Bakra.
Got it, Akshay. Got it. Timer please. Timer ready. 18 minutes.
So
timer.
4 minutes per video and 2 minutes extra.
This is Warangal Warriors. Warangal Warriors.
Intro.
Yes. Can you start the intro video please?
Good morning everyone. In today's Ophthalmic Premier League, on behalf of the Warangal Warriors, I, Dr. Kavya Chandran, consultant at the Shantilal Shangvi Cornea Institute, L.V. Prasad Eye Institute, Hyderabad, would like to take you through a case which is all about scoring the goal right. Like the famed Queen Rudrama Devi of the Kakatiya dynasty at Warangal, who travelled far and wide to protect her lands, this is the story of a young mother who travelled all the way from the US to India to seek treatment for her corneal condition. She presented with complaints of pain, redness and watering in her right eye. The clinical picture showed the evidence of sectoral corneal edema in the inferior half of the cornea with swelling of the superior half. On retroillumination, we could further appreciate the presence of endothelial vesicles in both the right and the left eye, the left eye being in an earlier stage than the right eye, which led us to the diagnosis of posterior corneal dystrophy. The specular microscopy showed absent cells in the central portion of the right eye, but surprisingly, the superior part of the cornea still had very good endothelial cell count. This being a progressive condition, we decided to go ahead with a DMEC compared to a DMEC. However, the DMEC was not going to be easy, and the specific considerations we had to keep in mind were to perform a careful desmotic to spare the healthy endothelium, positioning of an essential graft in accurate manner, a smaller size of the graft considering the level of involvement of the patient, and performing DMEC in a fetal patient with a clear lens. We accepted this challenge and went ahead with the surgery. The epithelium of the cornea was first debrided to increase visualization during the procedure. You can clearly see the endothelial vesicles in the central part of the cornea to the right. The amount of involved area was then measured with the help of telescopes, and the epithelium was quickly debrided. Once the graft sizing was noted, the eccentric mark was made with the help of a surgical expert. A tightrope was then made to inject pyrotactin to constrict the pupil. You can carefully appreciate in retroillumination the involved endothelium increases. An air bubble was then injected, and with the assistance of air bubble amplification, a careful desmotic access was done. Desmotic access has been meticulously done to avoid overlap of the graft with the peripheral host DM, which can increase the risk of detachment. Once the DM is carefully peeled from all corners, it is then examined to make sure that no bits are left in the AC. Using the help of forceps, this step can be completed further as well. Care must be taken to avoid damage to the crystalline lens and to the iris, especially in young patients who are phakic with a clear lens. After successful completion of the desmetorexis, the graft was then punched. 7.5 mm Trifine was used. A stromal cap of 3 mm is then punched to enable marking of the endothelial side. The letter P can be used to mark the endothelial side to ensure correct orientation during the surgery. The graft is then stained with trypan blue dye to enable clear visualization. The graft is then carefully peeled off and loaded into the Mealy glass tube. A superior clear corneal incision was made, through which the glass tube was injected and the graft was placed in the anterior chamber. The superior corneal incision was then sutured with a 10-0 nylon single suture. With the help of tapping maneuvers, the graft was carefully unfolded. The challenge here was to ensure that the graft was placed in an eccentric way and there was no overlap with the peripheral DM. Once the correct orientation was identified, the air bubble was then injected. With the help of a light pipe, we can confirm the correct orientation of the graft and to ensure that the margins are all well opened out. A bandage contact lens is then placed. The patient did very well, and her OCT on postoperative day 1 showed a well-attached lenticule, and a very happy family then flew back to their home in the US. I would like to conclude by saying that all's well that ends well, and careful and meticulous planning can ensure good outcomes in even complicated surgical procedures. Thank you for your patient listening.
That was a fantastic surgery, Dr. Kavya. Next, may go the microcornea. Now let us move on to the cataract in microcornea. Now presenting the case series. So this patient, a 44-year-old with total one-eyed patient presented. She was quite well managing since a year ago, then started diminution of vision. This was the case. You can see with comparison with a normal, this is a normal eye. You can just see the ratio between the needle and the cornea, and then the forceps and the cornea. So it was around then side, there's no place for the side port. This is just to compare how a normal situation. Then cortex, the entire chamber was filled with the probe. There's hardly any space for the maneuver. Then putting the lens again is a challenge. And then stuffing the haptics into the bag. The power was more than 50, but we could implant only the maximum available 39 diopters. Finally, you could successfully complete the surgery. Compare with the normal eye, how the optic sized with the people, then this is the microcornea. Post-operatively, day 1, she had corneal edema, but on 15 days post-op, she has fairly good vision. May go next video, my video. Next one, yeah. This is another case of 16-year-old male. You can see superiorly there was a defect in the jonules. Then the axial length was around 17.6. Then routine phaco we attempted. Again, you can see the sizing of the instruments. Our instruments are not suitable for these kind of cases. This is the one learning point we all should take from these cases. Then we have to develop some special equipment for these kind of cases like the pediatric equipments. The phaco needle, you can see the probe is entirely occupying the anterior chamber. And then very difficult. Being a young 16-year-old, there will be hardly any nucleus, so I opted for the complete aspiration of the lens matter. Here, this is slightly larger than the earlier case, so there is a space for the second instrument. And then we have to be a little gentle and patient about these cases. So after complete removal of the lens matter, insertion is again a challenge. So generally, the wound should be extended. And then with second attempt, I could stuff the lens inside. And then with great difficulty, push the lens inside the bag. So then complete the insertion technique. So post-operatively good vision, the take home, the power calculation, finding a right IOL, appropriate method, IOL sizing, and then finally we need to have developed one phaco needle which can suit these kind of cataract patients. Thank you all.
So they are still in a confusion who has to go next. Gopal Raju sir.
So Center for Sight and Warangal Warriors present Serendipity. So if I had to exemplify serendipity, it would be the story of this 32-year-old male patient who came to us with a gunshot injury to the right eye 2.5 months back. Multiple intraocular foreign bodies, vision was 6/18, and there was no sign of any entry site. Inside there was this resolving vitreous hemorrhage and 2 intraocular foreign bodies which were definitely evident there. One caught in the vitreous, thankfully, but one was impacted in the retina along the superiotemporal arcade. So as soon as I could release the first one, I thought I wanted to just remove it out of the eye so that it doesn't chatter inside too much. And unfortunately, my intraocular foreign body was not working. Intraocular foreign body forceps was not working, so I had to use the ILM. So I'm just removing the first metallic intraocular foreign body. It was around 2.5 to 3 mm, both of them. So I'm able to remove the first one. Struggled a little with the PVD induction here, but at least the good thing was I didn't have to stain the vitreous because we were already stained by the hemorrhage. And my idea was to just release the other foreign body also and take it out of the eye before completing the vitrectomy and then searching for the entry site. Finally, here I was able to induce the PVD. Young patient, so the PVD induction was also a little tricky. Didn't want to pull extra also. So here I'm trying to just release the impacted foreign body from its attachment to the vitreous and the retina. So there were multiple intra or bital foreign bodies also in this patient. And I call it serendipity because in spite of all that, his vision was 618 when he presented to us itself. So there I was like slowly shaving off the vitreous from that site of impacted foreign body. I didn't want to pull because there was an abnormal adhesion over there. So there I'm just slowly shaving it off to release that foreign body from there. And no matter how much I was trying and going close, I was not being able to release that attachment. With really low, this one I just finally could do it and then release the peripheral vitreous and the foreign body slowly released itself from there. Then I took this foreign body out of the eye also. And then actually the quest for the entry site began. We know that these are high velocity injuries. So we won't, maybe because the entry site was self-sealed, but there would be some sign. And there I found the superotemporal break. In fact, the break was so huge, it's just that the vitreous hemorrhage had maybe plugged that break and the patient did not have an RD. So sealed that up with a cryo, left with gas, and the patient's visual acuity in 1 month was around 6/9. Serendipity is all I can say. Thank you.
And we have the last presenter, Dr. Deepak sir, please.
Now, how do we deal with these capsules? We can either cut them, not tear them, and they're so thick and tenacious, your needle can't do it, and when you try to do it, there is always a risk of getting away. And Femto can't do it, Zepto can't do it. How are you going to manage this now? So, this is a real challenge here. Now, these patients are all elderly. We also have zonular laxity to deal with. So what is the problem here? I think the art of seeing the invisible, the hidden subcapsular calcified plaque is the one thing which we need to notice. And the solution is very simple, get rid of the plaque. Now, how do we do that? So, of course, once you stain the capsule, try to have an access to this plaque. Now, how do you get that? Is try to make a small central rhexis here. And even doing that is going to be a challenge, but you have to find a cleavage plane, do a small primary rhexis, and dissect out this plaque which is underlying the anterocapsule. So that is the plan. So first thing is always you identify this plaque. So here I'm using the 26 gauge needle to just create some cleavage plane for me, then to create a small primary rhexis. This rhexis is above the capsular plaque which you're having, the subcapsular plaque. So once we have done this small central primary rhexis, now we have the access to the underlying plaque. Carefully, with blunt dissection and with OVD, you're going to ensure that all the attachments to the overlying anterocapsule are dissected. The only skill you require here is patience. Be very patient, and still the job is not done. We can still see the tentacles of this plaque extending all the way up to the mid-periphery. Using a forceps, carefully tease this plaque out gently, separate it from the overlying anterocapsule and also the underlying cortex. A combination of viscodissection and using the same cannula and using a counter traction using a second instrument. With that, you can gently peel off all the capsular plaque. And once the capsular plaque is out, the rest of the anterior capsule behaves as if nothing was there. So you can see the key is getting rid of the plaque. Then the surgery is almost as routine as it can be. Similar case here. Again, an elderly patient with a hypermature cataract. Look at this calcific band which is extending all the way up to the equator. The only art here is to realize that the plaque is not on the surface but is on the underlying subcapsular space. The same plan, two-stage rhexis. First, get somehow a small, tiny anterior rhexis so that you can introduce a blunt dissecting instrument. Here, I'm using a flat iris spatula to go under the capsule, dissect out each of these plaques which is underneath it. And mind you, this capsule is vulnerable to tear. So you need to be as gentle as possible. Get out the smaller rhexis. Now we have access to the plaque. The plaque has to come out now. So using bimanual maneuver, because you can pull out the bag itself, using the second instrument to provide counter traction here, gently but surely, you're able to dissect out and manage to get this plaque. So the main villain is out now. Once the plaque is out, the remaining managing the capsule is just a piece of cake. This is how it is. So what did I learn from these cases? Try to realize that there is a subcapsular plaque which is there hidden under the anterior capsule. And if you can take care of that, these cases are a child's play. Thank you so much.
Thank you. Thank you for finishing well within the time.
Srinivas, just note down the time, how you have kept.
Yes, sir. 1 second late.
You should add 10 marks extra.
Yes, sir. Done.
1 mark extra, sir. 1 second overtime.
1 second. Dr. Arvind Moria, you saw their set of presentations. The first surgeon was scratching the cornea like what God if she was a neurosurgeon and scratching the brain.
Because he doesn't know where cornea is. He's a retina man.
The second surgeon is using such an instrument which is bigger than the eye.
Yeah.
There is something called as
Because you
bimanual
don't know
also.
the anatomy
Only
of the eye. What is
the
the size of the
coaxial.
eye?
And the third surgeon says the foreign body is not acting.
Yeah.
What kind of, how should the foreign body act? And the fourth surgeon, and the fourth surgeon is stretching it such a way that zonules का कोई चीज होता है कि नहीं है भाई? कोई नाम होता है कि नहीं zonules को? And he says only skill you need to is to have a patience. So that means anybody having a patience can do a complicated surgery.
But patience or patients?
Correct. So More sir, your thoughts on these things?
क्या बातें करते? ओटी में जाते बगैर प्रिपरेशन, आपका मैग्नेटिक फोर्स से अब काम नहीं करता, गलत बात. नो. सारा तैयारी के साथ जाने का, ऐसे नहीं जाने का.
Are you a patient or the qualified doctor?
Of course.
Madam, any comments?
Very impressive, but वो first video में इतना blue था, it was so blue, I got blue, depressed. And the second surgeon, the way they were handling cornea, it's good, Kavya, you're on the team. They'll need you.
Please wait, I'll get the pulse oximeter.
And no.
I will check the...
And also I liked it that
your
how
oxygen
they're using
saturation.
their own team members, no? The way Dr. Deepak is pulling the zonules, everything, maybe retina, I don't know. They'll need Rachita for sure. So it's good, very good, good combination.
Only good thing that the music, James Bond music.
Okay, thank you very much. You all did a fantastic
Big
job.
round
Very
of
nice,
applause.
beautiful videos. And you all know that nothing to take home seriously. These are all only the funny comments. The disclaimer comes, na. All this is fictitious. Nothing to be taken and nothing personal. So thank you very much, Warangal Warriors. So we have the next team, the 4 beautiful ladies. Please come over the dais, please.
The Hyderabad Hustlers, led by the captain, Dr. Somshila Murthy.
So what is Hyderabad about?
Hustling.
Hyderabad is not about hustling, and we are not hustling. This is a name given by Rishi. Where are you, Rishi? Hyderabad is about, I think it's about courage. Of course, it's about biryani, but it's about a lot of color. So, hey guys, cheer for the Hyderabad team. I refuse to say hustlers.
We have 4 of us who are representing
Timer, please. Timer,
beauty,
18 minutes.
brains, courage, and passion. So our first presenter, Abhilasha, is going to start for us. Go ahead,
Madam, they're
Abhilasha.
asking fashion or passion?
Both. No, no.
This is a uniform, madam, what you are wearing?
Absolutely.
What kind of uniform is this?
It is not
I'll
uniform.
start my presentation. Please start the timer because they are engaging us, wasting our time. Please start the timer. Wait. Please start the correct time.
Okay, start from 18 minutes, please. Yes.
Start from the beginning, yeah. So very often we are, the diagnostic dilemma is between infectious and inflammatory scleritis. So I'll be presenting 2 challenging cases. First case is a 65-year-old female with gradual onset of redness, pain in her left eye. She was on treatment already, history of cataract surgery with nucleus drop 2 months back, and underwent PPV for the same with uneventful post-op period. She was non-diabetic with no systemic history, although she was a tobacco chewer. Her left eye, you can see the scleritis with areas of suppuration and necrosis. So this is the picture in the left eye. Fundus is normal, no vitritis, no hypopion. The differential diagnosis at this point was surgically induced necrotizing scleritis or rheumatoid arthritis. My case 2 is a 45-year-old female with sudden onset redness, pain, defective vision in her right eye, followed by left eye. She was a diabetic, known Wegener's disease, with history of Aspergillus pneumonitis treated 2 years back. She was on maximum immunosuppression with steroids and cyclophosphamide. So this is the left eye picture. And you can see suppuration here as well. So this is immunosuppressed patient with suppuration. B scan shows dense vitritis with exudative retinal detachment. Can I have the audio, please? So differential diagnosis is endogenous endophthalmitis, and repeated scrapings were culture negative. For the second patient, the culture showed filamentous fungi. This is the first patient with suppuration, and she was diagnosed with Aspergillus flavus necrotizing scleritis. This is the first patient, non-diabetic, fungal scleritis. Was started on antifungals, topical as well as oral, and she showed a great response at 2 weeks. So you can see the suppuration has resolved. And this is after 3 months. Treatment was continued, and with 1 year follow-up, she's doing very well. Coming back to my second case, who still has suppuration, but here you see juxtalimbal corneal infiltrates. So this was actually worsening of a non-infectious scleritis. So this was worsening of Wegener's in a patient who was on maximum immunosuppression. So she was started on oral steroids, followed by biologics. And she as well showed dramatic response to the treatment. There was resolution of the exudative RD as well as inflammation in the eye. These patients have very high mortality. Those who develop severe scleritis have very high mortality. This is after 1 year, and she is doing excellently well. The fundus picture is also very stable. So these patients with inflammatory scleritis or infectious scleritis look similar, but we have to follow their behavior. Their behavior might be different. So as we see, so we have to follow their behavior. So in infectious, there is history of ocular surgery or trauma. In inflammatory, there is no such history. There is usually a hypopion in infectious, but no hypopion in inflammatory. In our patients, both were atypical. Infectious was immunocompetent, and non-infectious was severely immunosuppressed. So we should be ready for surprises. मुझे भी घर जाना है. Thank you.
Great job, Abhilasha. I'm going to talk about one of the cases operated by one of our colleagues from the other teams. And if you've noticed, all 3 other teams have some or the other topis. Hum topi nahi pehna rahe hain kisi ko. This is the case of the mysterious melting patch graft. So this is a patient who came to us all the damage was done elsewhere. The patient had undergone pterygium surgery 2 months ago. Then they had done a conjunctival autograft because there was a delin. Then the patient came with scleral thinning. And then we even thought that maybe there's infection because it looked so bad. But luckily, we could manage the infection. And finally, we had to take care of the area which was showing the thinning. The patient also had significant pain, was not responding well to the medication at that point. So we scheduled the patient for a patch graft. We did an amniotic membrane graft, but however, it just melted again. So we decided to go ahead and do more definitive therapy in the form of a patch graft. So what we had to do is, first of all, remove all the necrotic conjunctiva, which was not growing, not allowing the growth of the conjunctiva over onto the area of the defect. And this is what you're seeing here, trimming the edge of the unhealthy conjunctival epithelium. We hand-fashioned a small patch from preserved sclera, and we could put this in place with the help of fibrin glue, as well as we used sutures in order to put this in place. So this is trimming of the scleral patch. It is very important to make sure that you size it correctly. You don't want to have a large graft. So 4 anchoring sutures just to put that graft in place. And after that, we are also going to make sure that we cover the bare scleral patch that we have put here with the help of conjunctival autograft. We mobilize the conjunctiva by making a few inferior relaxing incisions on that conjunctiva, as well as we put an amniotic membrane, because amniotic membrane has multiple properties. It can help in rapid healing, as well as it provides collagen, which will help as a substrate. So this is we're taking a conjunctival patch graft from the inferior part of the conjunctiva and placing it on top of the defect that we have. So with the help of fibrin glue, we can very nicely stick the patch graft into place. And this is what the case looks like at the end of surgery. Unfortunately, the patient still had quite significant inflammation. So we had to start the patient on oral as well as topical steroids. Ultimately, at the end of 1 month, the patient was doing okay. And finally, post-op 3 months, the patient had completely recovered. Of course, the pterygium-like tissue had come back over there. So our patient was happy. We were also happy, but we're not happy with the surgeon from the other team who had sent us this patient.
So that was an excellent talk, Somshila, and from that we took the fibrin glue, whichever she left behind for our cases. So I'll be talking on the use of fibrin glue to close retinal breaks successfully in complex retinal detachments with silicone oil in situ. Now this concept of using it has been there for corneal perforations, leaks, surgeries, and for retinal indications also it has been reported for rhegmatogenous retinal detachments, but that is for simple detachments to obviate the need for tamponade. It has not been reported for complex retinal detachments and keeping silicone oil in situ. So this was a patient last July. We operated her for a complex PDR RD, and we failed as usual. So I thought there was nothing to lose by using fibrin glue for the break that was refusing to close. So I thought even if there are complications, this is a good case to do it. Because we were to lose the eye anyway. And there was an immediate reattachment, which we rarely see with conventionally operated cases. And you can see even at 8 months, she's doing very well. The retina is attached without complications. So then we started using it more often in difficult cases. This is a combined retinal detachment. And as the surgery proceeds, there is bleeding. All PDRs, they do bleed during surgery. So now I'm trying to remove the blood, but it never comes away. So it's very difficult to laser the breaks because of this blood. These are the 2 breaks. So then injecting fibrin glue over the 2 breaks. It comes as 2 components, so you have to inject them in 2 different syringes, one after the other. And you can see at 1 week there was some glue. At 3rd week it was gone. Retina is beautifully attached. And by the 5th week it's completely gone. So another case of bleeding during PDR surgery. The first component being injected over the 1 break, and then over the 2nd break, and then the second component of the glue being injected over the 2 breaks. just need to move forward. Move no, okay. So this is how we then used it for detachments. This was a patient who was a re-surgery with macular hole. We did a ILM peeling, but I was not satisfied, so put some glue over the macular hole. And you can see that by the third post-operative day, the glue has resolved, the retina is attached, hole is closed. This is another patient with old retinal detachment with macular hole. We put glue over the macular hole because we cannot laser a macular hole. By the 10th post-op day, the glue is gone and the retina is beautifully attached. So fibrin glue can be a useful adjunct in the management of complex retinal detachments, especially when laser for breaks is not possible due to bleeding, edema, or proximity to macular center or macular hole with RD itself. It obviates the need for post-operative positioning. Glue is not seen as early as 1 week to 4 weeks after surgery with no adverse effects with silicone oil in situ. We did not see any inflammation, IOP rise, or oil emulsification in the 10 months since we started this. Thank you very much.
Thank you, Malika. This is amazing presentation. And we move on to our last Hyderabad hustler.
Okay, so my question to all of you is mirror, mirror on the wall, and the answer is within you. So what is beauty? Beauty is all about the combination of qualities such as shape, color, size, aesthetic senses, and especially the sight. So Srinivas, your question, what are we wearing, lies here. So it's a work in progress. You see what is beautiful depends on what you want to see and want to perceive. This is something I wanted to share. So is this the beauty we are looking for? Is this where we are heading to? Of course not. I want to share my story because what else better than showing the mirror to yourself? This is how I started my journey, and the journey has been ongoing, and you can see myself standing in front of you. Whether it's a physical beauty or the inner beauty, the work is always in progress. You have to keep working on internal and external factors because beauty is both extrinsic and intrinsic. It requires a lot of work, it requires a lot of preparation, and we keep working on ourselves and our patients to assess their face, the facial shapes, the anatomy, the procedure which is to be tailor-made. There are different modalities which can be used, both surgical and non-surgical. We have different tools today in the industry to make you look the way you want to look. And what a best way or a better way to try it on yourself before you can offer it to your own patients. So, as I say, the eyes are windows to our soul. And if your eyes and the periauricular area is beautiful, everything looks beautiful. Why is it not playing? Okay, anyways, you can look at the eyes here maybe. That's better. Okay, so this is, I had a malar mount and how we had treated it at day 90 with the combination of both the modern and holistic treatments. And the same, based on what we experienced on ourselves, we experimented and implemented on our patients. So these are the real-time patients who can be given the beauty, what they're looking for in terms of their facial structures, the skin quality, and so on. And this is my mother, with whom I operated for lid bags. This or that is always a question when you give the mirror in the hand. Is this what you want, or is that what you want? And I end my talk by saying this.
This is a film about 6 remarkable women with an average age of 80.
I'm now 85, and I don't feel like slowing down yet.
6 women to inspire us and show us that old age doesn't have to be.
So old age doesn't have to be boring, and you need not age gracefully. Please age fabulously. So could you get the answer of mirror, mirror on the wall? I hope you did. Thank you.
Fantastic, Shubhra. That was a fitting finale to our presentation to the Hyderabad Hustlers. And back to you, Akshay and Srinivas.
So you have given us 4 minutes because the videos were so short. Sir, any comments? We were waiting for the surgical video, but the video got over. The only good part of that video was Sridevi.
Yeah, I was just waiting to see the eye. There is no eye nowhere.
No, you
they
couldn't see the
keep on
retina because
patching.
you've never seen the retina in your life.
Keep
As soon
on
as you see a
patching.
cataract, you get some panic attack. You rush.
Keep on patching here, patching
No,
there.
there was a lot of
using-
retina in the videos.
And then I think they have a share in Reliance or the Fevikwik company, then collecting all the things and then putting here and there.
No, we were not
They have
putting Fevikwik. We were putting
they have-
fibrin glue.
They have not put up the hats, they have put up the hats on the patient's eye.
No, I think
That was the Master Blaster. Anything, Rishi?
I think they were very good presentations covering different aspects. So congratulations.
Diplomacy in OPL is not allowed. You can sit here, hide and say this.
Disqualified.
He's being honest. He's being very
Comments
honest.
to
We love you. We are happy to be called as Hyderabad hustlers now.
I think Dr. Gopal Raju should understand the difference between fibrin glue and Fevikwik. I hope you don't use Fevikwik in the eye. Is that the case you got the other day?
Somashila's case, I have not seen any difference between pre-op and post-op. It is same.
But patient is happy. You heard that?
So maybe the periocular field vision is restricted for you. So maybe you have dermatochalasis. Please come to me.
All right. A big round of applause for Hyderabad hustlers.
Wait, Dr. Akshay. There are still many people who are raising their hands that I want to comment.
Please hustle them.
I don't know why you're not having gender equity. We always keep on talking of gender equity. Where are the men in your team? Come on. This is too much.
We are too good to have men around. It's fine, ma'am. We're too good to have men around.
I believe in gender equity. Just like I don't want the men's
this is
team
not
not
a
to have
selection.
women.
So I just want to clarify that this is selection by the committee. We didn't play any role in telling them who we wanted or something.
But you
like
could
that.
have protested and told the committee
No,
that
there
we
is
don't
either-
like it. No, you can tell we don't like it. Don't go into situations which you don't like and which you don't think are fair.
But why are you assuming that we don't like it? We like it. Why are you assuming?
Yeah, that is the problem. People start liking things which are not equitable.
No, we like it, ma'am. But the problem is
They
nobody is
are-
coming
No,
closer
even
to
in
us.
their videos also gender bias.
Inequity in the
No.
judges.
It's called
Even
the
in
gender
their video-
superiority, not bias.
Yeah, unfortunately, the captains were not involved in the team selection. That's what they are saying. So only the owner or the CEO, Jay Shah only actually appointed all the captains, team players.
Jay Shah is sitting here.
So unfortunately,
Hairstyle matches
I
Amit
think you are
Shah.
not also getting any match fees also. You are playing for free only here. I think all the money someone else is taking there. But can we have a strategic timeout? I think the audience also may want to have some popcorn drinks or anything. But overall, I would like to say that, very nice play, like front foot defense, back foot defense. Many of you left the ball very nicely. But I wasn't sure whether I was watching Ranji Trophy or even net practice probably. But this is actually Premier League audience is sitting there. They want to see, reverse sweeps and reverse hit shots also. And the point is, actually it's a default no ball. In a no ball, you never get out. So the entertainment part is probably lacking quite a bit significantly. And that is what the audience would like to see overall. I see some of them have tried to bring in entertainment also. But I would say that this looks between Ranji Trophy and net practice match so far.
OPL is basically an infotainment, information and entertainment. Thank you very much for the ladies who are in uniform, but they are not uniformed. Thank you very much. So next we go on to the next team.
Nizamabad Nawabs.
Wow. Judges, please take into consideration the costume they are wearing.
Again.
I'm not highlighting.
Captain-
I'm just remembering. Why
captain
are
is
you so
capless.
jealous? Why are you so jealous, Dr. Deepak? You should be sportive. The judges like the sportsmanship here. And the best judge, whatever dressed, male or female, will be by the audience, not by the judges. The judges will do for the scientific.
No. So I think you have misunderstood. We are on-field umpires. Every decision will be by the third umpire only.
So please, audience, please, we'll ask one by one, and you have to vote who is the best dressed person in this OPL. Okay, so
All set.
again,
18 minutes.
There is a
Start.
mismatch. Where is your cap, sir? No hat?
It
You are
didn't
not a
fit
Nawab?
me. That's all right. I'm not competing for the best costume. So we have Nizamabad Nizams, and we have a great team. We have
Audio.
one cornea specialist, one cataract specialist, one glaucoma specialist, and of course one oculoplasty. So we start with Vinit.
I'm taking Dr. Raja's comments seriously. So since he's giving all the cricket metaphors, let's start with some shots here. I'll be taking across a case which I just saw last week. Just a second.
Intro video.
Please unmute yourself.
Okay. Audio, please. So this was a case, a female presented with corneal decompensation only in one eye. And as you can see in the scans, the endothelial cells in the one eye showed abnormal cells. These were the eye cells with enormous pass across almost 8 clock hours of pass. And these are developmental anomalies typically associated with secondary glaucoma, crowded anterior chamber, and you have to deal with a lot of complications here. So how do you manage a cataract and endothelial keratoplasty here? So we preferred DMEC here over DSEC. And the reason here was that there are these abnormal eye cells which cause these pass formations. So we thought of removing these cells and putting a DMEC graft which will allow the migration of the cells in the periphery, which is not possible in DSEC. So as you can see here, that this chamber is extremely crowded. There is no space to place a graft, and almost 10 clock hours of synechia. So here you have to do a goniosynecholalysis very gently, like 1 to 2 clock hours at a time, and release them slowly so that you can start seeing the space and the anterior chamber opening up. And plan your incisions in such a way that it doesn't come in the way of pass. And always tackle the pass 180 degrees opposite when you want to release the synechia on the other side. Don't pull anything, otherwise it's going to cause a iridodialysis, and it is already a case where you're going to deal with a lot of fibrin. So you want to open your DMEC graft properly, you have to take care of the fibrin. So I'll tell you how to take care of that. Now the problem here is that the lens is always cataractous, it will try to push ahead. And because of the secondary glaucoma, it's better to do a triple procedure in the first go itself. So it's difficult cataract surgery. You have to do a rhexis in a small pupil. But here the advantage is anyways you are going to do endothelial keratoplasty, so you can take the nucleus out in anterior chamber and go ahead and do a phaco. Just the only thing you have to be cautious about is not to touch the PC and put a lens properly in the back. So a 3-piece lens is preferable because that gives the adequate space for air bubble manipulation. Now these are the extra steps in manipulation in ice syndrome, where you have to remove those peripheral damaged tissue which has ice cells. So nicely take it off during the desmetorrhexis, and once that is out, you have to look for the tags. Now these abnormal ice cells, they form a lot of thick adhesions in the periphery with the Descemet's membrane. So these have to be removed with a micro forceps. As you can see, you actually need some force. Again, slowly, 1 clock hour at a time is the best thing to do. Now you can see there is a lot of blood in the anterior chamber. So I'll show you how to take care of it. Now this is something new that we have started in our eye banks in LVP, where we have pre-stripped DMEC grafts that we get. And this was a big save. It was a savior for me because I had to undersize my graft in this case because of the pass. So I placed an AC maintainer to clear off all the debris and fibrin, and I undersized the DMEC graft to 7.5 over here millimeter to a routine that we use 8 millimeters. So undersizing is important in these cases. The graft will tend to be a little naughty. It will not open up clearly because of fibrin in anterior chamber, and so the AC maintainer helps here to clean away all the debris and blood. So as you saw here, it was inverted when I saw on the retro illumination. So I'm trying to reverse flip the graft, but it's not opening. But eventually it does. You have to be persistent here, and luckily it just fit in within those anterior synechia. And then As you can see, the bubble, now the size of the bubble has also increased after goniosynoculitis, and the patient did well. So these techniques we summarized in one of our publication. We followed 5 cases over a period of 3 years, and we published this in Cornea. And these surgical steps, we believe, are responsible in causing less secondary synechia, and the outcomes have been very good. So thank you.
That was excellent presentation, Dr.
Thank you, Vinay. That was excellent. Now, Praveen, who shows a complicated cataract surgery.
So very good afternoon, all. That's part of the phaco in the small people. So when I tried viscometastasis and intracameral metatrix, the people was not dilating. So I was skeptical whether to go with the pupillary expansion devices or I should go for phaco straightforward. Then my gut feeling said better to go with the phaco directly. So I done the Rexis comfortably, and the hydroprocedure also was comfortable. Here I went little anterior, my incision little anterior, because there are few modification in the phaco in the non-dilating or small people. So to avoid iris prolapse, the incision will be little more anteriorly rather than regular. So hydro procedure went uneventful, and the rotation was very smooth. And I started phaco. So all my phaco parameters been reduced, flow rate, vacuum, everything been reduced. And the key point is always phaco should be done in the center of the pupil. And I request judges to consider, as I'm a debut for the OPL, you should consider me and give a little more marks to my team. Sorry.
No, sorry, allowed.
Sorry for taking a little time.
Is this the same case? Or?
Yeah. Then bimanual aspiration is, irrigation aspiration is more ideal and preferable in these situations. So slow motion phaco with bimanual aspiration is a key, and keeping the phaco tip always in the center. And implanting hydrophobic IOL in the bag and checking out whether in the bag or not. And coaxial later for the viscoaspiration. So uninterventional phaco surgery in the small people. Thank you.
Thank you, Praveen. Siddharth is next, and he goes with a patient with intraoperative aqueous misdirection.
Thank you, Dr. SH. The challenge does not appear always in your preoperative examination. Sometimes you go on a ride thinking that everything is all right, but you need something to tackle a problem that has come up suddenly. And that thing is Unnagi. So this was a high myope with primary open-angle glaucoma, and suddenly in a normal phaco, I started having iris prolapse. No matter what you did, the iris would not go back, and the PC was coming very close to the endothelium. And with this happened when I was doing cortical aspiration, and for a moment when you just come out and the anterior chamber shallows, it didn't form again. No matter how much Helon you would push in the eye, no matter how much you would try to reposit the iris, this was not going back. Any attempts to do the cortical aspiration was very risky, was feeling very risky because the PC was really bulging. I thought I will just push the IOL in, push the whole bag out, but even that was very difficult because the iris was prolapsing continuously and I was risking an iridodialysis if I was trying to force the IOL into the eye. So what was I facing? What is this? This is not something that is very well described in literature. It has got various names and various terminologies. So I had to go back into the memory palace and realize that this is nothing but aqueous misdirection. How did I reach this conclusion? Once you have ruled out that the patient is not straining because of any other reason, your speculum is not tight, and the glow from the retina is absolutely normal, this is nothing but acute intraoperative aqueous misdirection. Now, typically the approach is either to abandon the surgery, call your vitreoretina colleagues, use mannitol, or do a needle aspiration, all of which are risky or complicated. So I thought, why not do something that we do for chronic misdirection? And that is IZHV with these particular settings. Now, these are settings that we use for IZHV in chronic aqueous misdirection, and this is what I did. So using Alcon vitrectomy with a 26G probe, what was done was go through the iris, the capsule and the zonules, and if the diagnosis is right, the moment you go rupture the capsule and the anterior hyaloid face, the entire AC will form, and whatever problems were there will disappear. So you will notice what is called the snap sign, usually not welcome by an anterior segment surgeon. When the anterior hyaloid face breaks, just see the pupil moving. And this is the moment when the anterior hyaloid face is broken. I'll just play this particular moment for you again in slow motion. And what usually is a bad omen was the beginning of good times for the patient. The surgeon was very happy, and in this high myope who needed a 3-piece IOL, I could easily place the IOL thereafter. The surgery was quite simple after this. And the patient had visual acuity of 20/40 on day 1 and 20/25 thereafter, and the problem never arose again. Thank you.
Thank you, Siddharth. That was really wonderful. Can I have the sound, please? We have seen a lot of cataracts and cornea today, so we'll see something different. This was a lady with an anterior dermoid where we would do direct approach, a small incision, dissection around the lesion, making sure that the capsule does not rupture. Don't hold the lesion itself, but hold tissues around the lesion. Go around it and excise it. This was a slightly difficult situation where there was intraosseous extension through the frontozygomatic suture. Incision is the same, but we have to be careful when we dissect the base of the lesion. We have to dissect the periosteum as well. That's subperiosteal dissection to reach the suture. Excision in flush with the suture, and then the rest of the extraorbital component is curated. This is a deeper dermoid. A large deeper dermoid without much of anterior adhesions, but posteriorly we have some adhesions to the periosteum. Here we use a cryoprobe for anteroposterior traction and gently dissect the lesion out. This is a much larger variant. With a very thin capsule as well. perilesional dissection. This one had sutural extension, so we were very careful and we wanted to know the contents of the dermoid before excising the sutural extent. Because at that point, there was a possibility of rupture. So you'll see at some point in time that I did transillumination to know the contents of the dermoid. It was clear content. So we had, now once we determined that it was clear content, we excised the sutural extension. This was a difficult patient who did not want a scar at all. They used foam sclerotherapy. This was a patient where there was a dermoid with fluid content, which we had already determined by CT and MRI. So center of the lesion is marked, fluid content is aspirated, sodium tetradecyl sulfate is formed. Thank you so much.
Thank you very much, Nawabs. Somshila madam, actually to be very frank with you, the first presenter is also Dr. Joshi, and I thought him to be my brother. I told him also, can you just stop the video? And I told him also that you are like my brother, big brother or small brother. The way he was scratching and manipulating the cornea, I think now it has come the time for me to disown him, madam.
More than your brother, he's like your daughter now, scribbling on the paper.
And he's just handling the cornea in such a way that I remember those days when my daughter was scribbling first time on the paper. So that kind of scribbling I had never seen, madam. What do you say about this?
I completely agree. Vineet, I also disown you. This is not what I taught you. What were you doing?
Thankfully, that helped us, the publication, the scratching part.
Yeah, that was quite a horror show, the first presentation, Dr. Joshi. I think you have to screen the videos before you allow them. It was a horror show. And Dr. Dikshit, I think you were missing a suprachoroidal hemorrhage. I think that was an expulsive hemorrhage which you just closed, because that is exactly how it presents. But maybe you've never heard of it.
No, the proof of the pudding lies in eating. If the snap sign resolves it, a suprachoroidal hemorrhage will not resolve with IZHV.
You have just closed the case. We don't know what resolved. We don't know what is the post-op vision. We don't know. What was the post-op vision?
I showed the first post-op day pictures.
That was only the cornea.
Okay. Sir,
I
any
think
comments?
for
No.
Dr. Praveen, if I can say, use mydriatic cycloplegic pre-op. Don't miss that step. Don't be in a hurry. Use.
I think the only technically difficult part of that was running the PowerPoint smoothly.
And that's why I asked for excuse.
पायलो क्यों डाला? पायलो क्यों डाला? दीक्षित साहब तो ऐसे दिखा रहे थे, वो साला कोरोइडल आगे आ रहा था, पीछे जा रहा था, आइरिस आगे आ रहा था, बाहर आ रहा था, देख के माधुरी दीक्षित का डांस याद आ गया भाई. Yes, मौर्य साहब. Go ahead.
पायलो क्यों डाला? प्री-ऑप. पायलो क्यों डाला प्री-ऑप?
फिर ओपीएल का वीडियो कैसे बनाएंगे? Alright. Thank you so much.
आपका टीम तो और भी खराब है कि इसमें तो एक तो डाइवर्सिटी नहीं है, ऊपर से मेन जिनका पता कि वो काम नहीं कर सकते जैसा फीमेल्स करती हैं, तो भाई कुछ तो सोचो ना कि अच्छे सर्जन को लाओ जो बहुत डेलिकेटली काम करेंगी, छोटे छोटे हाथों से, प्यार से. कहीं भी प्यार नहीं दिख रहा था, कहीं भी केयर नहीं दिख रहा था. इस वजह स्क्रैम्बलिंग जैसे मैन करते ना, अब ये करना है वो करना. अरे यार थोड़ा प्यार से केयर भी सुना कि पेशेंट को खाली सर्जरी का जरूरत नहीं होता, उसको केयर भी जरूरत होता है. वो तो तुम कर नहीं सकते, तो एक लेडी को तो साथ में रखते ना.
अरे ऋषि भाई, नेक्स्ट टाइम जलाली मैडम को लगा दो सिलेक्शन टीम पे. Okay, thank you very much. Any other comments? I think we'll move on to the next team. Thank you very much, Nizamabad Nawabs. That was a wonderful presentation. Thank you.
Right. So Karimnagar Kings.
Very good.
मैडम पहले ही डाइवर्सिटी के बारे में बोल देंगे, फिर बाद में वीडियो चला देंगे.
हाँ चलो हाँ उधर लगा मेरा लैपटॉप यहीं लगेगा इसका. हाँ तो यहाँ लगा लेंगे, बीच में गैप आएगा. नहीं एक यहाँ एक ऐसे नहीं करना. नहीं नहीं ऐसे यहीं से करना. हो गया. यहाँ क्यों नहीं रहा इसमें? इट इज नॉट ओपनिंग. इधर ही रहिए आप. ओपन नहीं हो रहा.
So you have an intro song, More sahab?
Ah, we have.
Okay, good.
It's not running.
So now we have the last team, Karimnagar Kings. But their video is not working.
Play from there. Volume, volume. Volume, volume.
हाँ तो और कितना वॉल्यूम?
First shot. First shot. ये वाला करना है. ये open it. Yeah, this one. Dr. Inder will present on a complicated cataract case.
Start. Yeah. Good afternoon. Yes, very hypermature cataract case. My bad day, but still I managed it.
सर गॉगल निकाल के एक सेकंड दे.
अरे गॉगल निकाल दीजिए इंदर भाई.
दूसरा प्रेजेंटेशन चल रहा है.
दिख जाएगा किसका प्रेजेंटेशन चल रहा है.
Yeah, it's a dead ball.
ये इनको कौन पैसा दिया? राजू सर.
पैसा नहीं दिया, पैसा नहीं दिया कुछ, इसीलिए.
इसलिए रोक
कोरा
दिया
कागज है वो, कोरा कागज.
वीडियो स्टॉप कर दिया.
There is match fixing allegation.
Reset the timer.
No, we can't do that. Sorry. I've told you, technical errors will include 2 minutes.
बाद में मिलते हैं. बाद में मिलते हैं.
सर? हाँ, लगा रहा. क्या नहीं आता वो मुझे नहीं पता, वो आगे पूछो.
Play from there.
Yeah. So hypermature cataract, bad day, and started the surgery. Single-eyed patient. Yes, everything was going smooth, but I couldn't complete this CCC. Still there to do cataract surgery, soft cataract. All things going well again. This was my second problem. The PCR happened in such case again. Did, approach surgical soft cataract surgery approach. Tried to manage in a better way. Plan to do. So
things were going well. I did completed the surgery, but then planned anterior vitrectomy because the cortex was still left over. Anterior vitrectomy from the anterior root was completed again. Thing is like that because on a bad day when you get such cases, patient demands surgery, and something you have to give, that you have to prove yourself also. Sometimes in a single man setups, retina surgeon is also not available, and 3-piece IOL was also not available, so I again implanted single-piece IOL. IOL was single piece in the sulcus. IOL was well centered after that. And ultimately, the things were settled. I could give the patient good vision post-operatively, and the patient was happy and satisfied. Yeah. Cornea was clear, well managed. Thank you.
Excellent management. Very great vision.
Just connect it fast.
Now Dr. Varun will present his refractive cases.
We don't lose much time.
You are losing time, Dr. Moria. 12 minutes.
No, it's technical glitch.
No, there is no technicality.
Not our fault. No. No.
Yes, I'm just presenting here a couple of my smile videos. So as you can see here, with a blunt dissector, I have made the anterior planar entry, and now I'm doing the anterior planar dissection. When the opaque bubble layer is extremely uniform, it is easy to have your dissection, and you can complete it on both sides. As you can see here, your dissection keeps on increasing as you go inside the cornea and as the opaque bubble layer starts to clear up. After I completed both the anterior and the posterior planar dissections, I have now caught hold of the cornea and taken it out with the help of my corneal forceps. And then I could see a small reflection inside my stromal pocket, and then I realized that the lenticule has now split and a small part of the lenticule has been left behind. Now, like a thief, I was now trying to see how do I barge in and sneak in. So I tried to make 3 different entries here. First of all, I try to go into the anterior plane and separate this retained lenticule from the anterior cap. Once I have successfully done that, now the more difficult part starts, which is to go into the posterior plane. And now I try to make 3 different entries. I try to see 3 different windows, and I try to realize how I can enter into this house and then, probably, do a theft and take this piece of cornea which is left behind in the stromal pocket. I had to tilt my spatula vertically to nicely separate this. Now this is full of danger and requires a lot of boldness, and I'm just trying my best to complete it in the same sitting itself. Otherwise, another option could have been to defer the surgery and convert it into a circle procedure. I try my best, like a rhexis, I rotate and then take the piece out. This is another case wherein I'm just using a blunt dissector and trying to make an anterior planar entry. After that, I'm trying this posterior entry also. And now with the help of of the other dissector, I'm trying to enter into the posterior plane. However, I'm unable to find it. Now I feel that the posterior entry has also been made. And now with the help of the spatula, I go inside nicely and complete the dissection. As you can see, we make the viper-like movements from side to side. As you find the right plane, your speed of dissection also increases, and your heart rate of the surgeon also starts to settle down. Now when I try to go into the posterior plane, my spatula is now slipping again and again as if it's a muddy football field. I'm trying to just find the proper posterior plane, but I'm still being unable to find it, despite repeated attempts. So now I take a reverse in skis hook. Now, like you start a Bajaj scooter by moving it from side to side, I have taken a reverse in skis and I'm trying to play with the lenticule from side to side, and finally I'm able to now reflect a part of this lenticule. As you can see here, I was able to reflect the lenticule enough. Now with the spatula, I go into the anterior plane. I hold the lenticule with the help of a forceps to give it fair amount of traction. And now, as you can see, my heart rate comes down. I think the surgeon also should have a PAC done, before we go for a refractive surgery, so as to look at the health of the surgeon, which is very important sometimes. And now, finally, I pull my lenticule out. Sometimes these smiles can cause a lot of tears, so I call these teary smiles. Thank you.
Very well managed cases. Correct. Yeah. So, yeah, yeah. So this was a very challenging case, one-eyed chronic ankylosing glaucoma with conjunctival chemosis, hazy cornea, shallow anterior chamber, and floppy iris, whatnot. So we started by doing gently. This scleral flap was made, and then side port was done. So here I was able to know that it is a floppy iris. Blue dye was pushed for proper staining, then cohesive viscoelastic, and a 4.75 continuous curvilinear capsular axis was made. And you can see the corneal incision is anterior. Still the floppiness of iris is too much. So gently I made this rhexis of 4.75. So finally it was done. Now entry with the help of 2.8 keraton. Again one anterior side port for the chopper, gentle hydrodissection and delineation. It's organized. So there is no ring of steel scarring in such cases because they have pores. So there is always a functional bleb with a normal conjunctival structure. So this is how it works after it dissolves on its own. So after 6 months, this is a picture after 1 month, a functioning bleb, IOP 9 millimeter of Hg from 45, and best corrected visual acuity was 612. So a teamwork always lead to happiness and a happy patient. Thank you so very much. Dr. Murli,
Malika madam, I know you are full of energy to blast them, but still one more video is there, madam. Please allow them to present. Oh,
so I get
we'll give you some
started
beta
with my
blockers
case.
now.
So I'll be presenting a case of extreme ectasia. So this was a case, middle-aged lady referred from a Lucknow, from a RP center, and nobody knows the diagnosis, and nobody want to touch this particular eye. And she had a corrected vision in the right eye, 20/80, with -18 diopter of astigmatism, left eye hand movements. If you look at this photograph, you would see eyes are very prominent. I think, this suggestive of, something keratoglobal, something, inside these lids. If you look at an extreme ectasia, this is a kind of extreme ectasia which I've never seen before. You could see that, this is almost resemblance that of a spatica linga, okay? So you can see the limbus is stretched, and this part of the cornea is barely 150 microns. Even a simple touch can actually lead to the globe rupture. I have to be extremely diligent, even the way I examine her in a slit lamp. And this was, I was referring to the spatica linga. No matter how good a surgeon you are, at times you need a divine intervention. I'm really praying for my favorite god, Hara, here to give me some weapon so that I can tackle this particular case. This was the OCT, which clearly shows a large eye drops due to an extreme PMCD, posterior peripheral marginal degeneration. So OCT again corroborative of the same. So how do we tackle this particular problem? Doing a keratoplasty, large keratoplasty is the only way we can actually get rid of this condition. So I'm praying Shiva to give me a weapon like a trishula. That's how I started this surgery. So I was very obsessive, carefully draped the patient, applied speculum very carefully not to rupture, and using the Trishulastra to destroy all demons in the form of a keratocyte and lose abnormal keratocyte in order to shrink. Again made an opening, further flattened, so that I need to end up having a good contour before I embark on a keratoplasty, before I create a peg on this abnormal cornea. So I took a lot of time. So prepare my bed using a right form of a trifine to mark, and most of the steps I did a manual fashioning the peg with a great difficulty, excised entire cone, and needed about a 13 millimeter, quite a large graft. So this surgery may be one of the tough surgery for me. Took a nearly 1.5 hours to complete. And each bite has to be carefully taken because it tends to cheese wire in order to prevent the peripheral break. I also did a peritomy in this particular case, and at the end I'm draping that conjunctiva all around to create an artificial kind of a limbus. Intraoperatively it was looking good, and postoperatively as expected. And postoperatively, she did an appreciable vision. In 3 months, we could get her to 20/50 with less than 2 cylinder. And these pictures are quite evident. Even such a difficult cases with the, of course, the divine intervention, we can, bring the smile back to these faces. So one has to be very careful about the imminent complications, and a close long-term monitoring is a key in managing such a difficult cases. Thank you for opportunity.
Just wow, Murli. First you tell, then we'll give it to them. Yes, Akshay?
No, I think are some of our team members forgetting the concept of OPL? It is challenging and interesting cases. I thought a couple of them were routine cases they did yesterday in the OT and came back.
इंदर भाई तो ऐसा प्रेजेंट कर रहे थे, वो साला नरम कैटरैक्ट था, बहुत सॉफ्ट था. तो सॉफ्टली आपने ऐसा इंस्ट्रूमेंट लगा दिया, वो ऑप्टिक डिस्क पल्सेशन दिखना लगा हमको. ऑप्टिक डिस्क बोलने लगा मैं कब बाहर आ जाता हूं, मैं कब बाहर आ गया. इतना आप ऐसे झगड़ के रगड़ के खींच रहे थे.
No,
anyway,
Srinivas.
And वरुण भाई तो क्या स्माइल करते करते खुद स्माइल करना ही भूल गए. देखो ऐसे स्माइल करता है, ऐसे स्माइल करते हैं. और मौर्य साहब का क्या कहे, अरे भाई वो फेको बोल रहे थे, इन द बैक कर रहा हूं. थैंक गॉड इट वाज इन द आई एट लीस्ट.
Actually,
and मुरलीधर सर का he did a phenomenal job. क्या सर्जरी था सर. लेकिन दूसरे आंख में टोसिस है, तो आपके ऑक्यूलोप्लास्टी सर्जन नहीं है सर?
yes. नहीं सर, वो फेको वीडियो ना एक्चुअली वो इनोवेटिव सेशन में जाना था. एक्चुअली वो गलती में ओपीएल में आ गया है. पंचोरेक्सिस ऑफ एंटर कैप्सूल, पंचोरेक्सिस ऑफ पोस्टर कैप्सूल, यूजिंग फेको टिप फॉर डिफरेंट टाइप्स ऑफ रेक्सिस, इनोवेटिव वीडियो में जाना है.
गोपाल सर,
instead of surgeon PAC, you have to get the surgeon physician clearance also.
Yeah, quite horrifying videos. And even the horrifying surgeon, I must say. Dr. Inder Rastogi, you were talking about your patient's cornea was clear, but we are wondering about your cornea because you're not removing the glasses. Is that photophobia, which is why you're not removing?
Nothing.
There must be some reason. There might be some corneal problems.
No.
And Dr. Arvind Maurya, you were talking about floppy and chopping, and then naturally the patient goes into bradycardia. And I'm not surprised you need IV line for all your patients. We don't need even for vitreous surgeries, but you need for your cataract surgeries. I'm not surprised. And please continue to keep IV lines. Thank you.
All right.
I think your team has chopped and chopped enough. So, oh yes, ma'am.
So now it's the time. Thank you
नहीं,
very
जोशी
much.
साहब, एक चीज तो बहुत ही ऑब्जेक्शनेबल है. यहाँ पे इतने बच्चे हैं, उनको अच्छा कल्चर सिखाना है. यहाँ पे कोई बोल रहा है मैं चोरी करूंगा, कॉर्निया की चोरी. I mean, how can you use that language in front of the kids? You could have told no कि मैं facilitate करूंगा या मैं कोई. I mean, use positive words. चोरी वर्ड आप बोलेंगे, आप टिश्यू की चोरी करेंगे, क्या क्या चोरी करेंगे. आई प्लीज बच्चों को अच्छे संस्कार सिखाओ भाई. आप कैसे टीचर हैं, चोर बोल रहे हैं. I mean, everybody should object to that word.
Madam, we borrowed Trishul, we didn't, steal. Come on.
Okay, all comments to be taken on a lighter vein, nothing personal. As I said before, these are only fictitious, which are not to be taken personally and not to take home any of these messages. Apart from the beautiful scientific videos all the team has shown, I think they need a wonderful crowd of applause, please. Thank you very much. Thank you. Yes. So now the scorers will be announcing the team. I request all of you to please stay. Till then, we'll play the video. Lights down. Voice. Volume. One scientific individual winner and runner होना ही चाहिए. Scientific एक डालना है, entertaining डालना है. That's why we said no. Last time, scientific आप लोग बोल देंगे. One scientific. Okay, thank you very much. Thank you. I request all the teams to please come up on the dais. Now will be the final round of who is the winner and who are the runners, and rest of them are all losers. So we request the judges to please say a few words before we go on to announcing the results. Yes, Rajalingam sir.
Yeah, it is very entertaining. Everybody presented actually scientific content is excellent. And but only thing is, as Raja said, the entertainment part is most of the presentations are missing. Everybody did very well, excellent. Thank you. Congratulations for everybody.
Yeah, so again, excellent presentation. Very serious. Some of them are very light, like I said that, the playing conditions are different. Like, cloudy, raining. You have already decided I will play only these players. They have to select the correct player for that time, for that condition in the pitch or match. And whenever we have pre-decided I will do this technique and this IL only, then it will create problems. You don't handle accordingly. So I think overall, the entertainment part, whenever the video is showing, audience here is the main focus of our presentation. I mean, obviously the scientific message has to go through. But at the same time, when we will have third umpire decision is pending actually, they have to decide out or not out.
We feel the same. In the mornings, all 3 days, we have scientific programs. We should be more entertaining along with the scientific content.
And the problem is, the smile surgeon also very serious. That is the whole problem. And another surgeon, as our FACO parameters, his heart rate BP is always showing by the side of the BP. And मेरा heart rate बढ़ रहा है, और कम हो रहे हैं. Just like FACO parameter, he is keeping that his heart rate and BP along the side of the BP. Excellent, wonderful.
I think judges are telling that it's a close call. I request Rishi also to please come up on the dais, and Akshay doesn't want to give us the papers. Akshay? Okay, till then we'll go with the best costume. The best costume, as I said, will be announced by the audience, right? Karimnagar Kings, how many votes do we have? Quite a few, yeah. Hyderabad Hustlers. Nawabs. Warangal Warriors. Okay, so we have the clear winner. ओके आप दोनों आगे आ जाइए. आइए दोनों टीम आगे आ जाइए. Yes, boss. So how much for Karimnagar Kings? Okay. And then now how many we have for Hyderabad Hustlers? It's very confusing. I call the judges now. Please, please, please bear with me. One last round of vote, please, judges. I think you have to decide on that because I don't want to get blamed. Okay, again, one last time. Please, not raising for both the teams. I've seen some of you are raising for both the teams. Only for one team. Okay, now we have Karimnagar Kings voting, please. Final. Only one hand, please. Okay. And then we have Hyderabad Hustlers.
It's a very close call. Even the third umpire is not able to decide. So both of them are winners. We can give trophy to both of them.
Thank you very much. I think, wait, madam. You are the winners, they are the runners. It's okay, compromise. It's okay, you are the winners, they are the runners. Don't worry, we give you runnership. So here we give the winners, best dressed team to Hyderabad Hustlers. Please hold it. Hold it. All of you hold together. Judges, all the judges, please. Akshay. And we have the runner-up, Karimnagar Kings. Thank you, thank you, thank you. And now we come to the best scientific video. Any guesses for the best scientific video? Any guesses? No, it's best scientific depends on the single person. Okay, let's quickly have the audience poll. Yes, Murli sir. Dr. Santosh. Then Dr. Praveen. We have Dr. Vineet Joshi, my brother. Please vote for him. And Dr. Indarbai, Dr. Maurya, Dr. Varun, Dr. Abhilasha, Dr. Malika, Dr. Somshila, Dr. Shubhra, Dr. Gopal Raju, Dr. Deepak Megur. Okay, we see quite a few hands. And Dr. Kavya and Dr. Rachita. Okay, can we have the final results? Akshay, you want to announce who is the best scientific runner-up?
The runner-up for the best scientific video is Dr. Murlidhar.
Okay, and the winners goes to
Dr. Santosh Honavar.
Woo!
For the video Dancing with Dermoids by the surgeon whom we have never seen dance.
Thank you very much. And now comes the best entertainment video. Any guesses? I'll not go with a show of hands. Any guesses for the best entertainment video? Okay. The best entertainment video goes to Dr. Siddharth. Dr. Siddharth Dikshit. Yes, man, gone for the other side. Your team wants to receive it. Dr. Vinny. And the runner-up for the best entertainment award. Any guesses? Yes, right, Dr. Deepak Megur. Thank you very much. Now, the runner-up, the best team. Overall best team. Okay? Now we'll go with the show of hands again because it's not an individual. It's okay. Anybody can take that honor or the credit or disregard. So we come to Nawabs. How many of them would like to vote for Nawabs for the best team? Overall best team. Okay. I do see queue out of hands. And then we come to Karimnagar Kings, please. Hyderabad Hustlers. Oh, not bad. And then we come to Warangal Warriors. Okay, not bad. But here I think the judges' choice are slightly not matching with the audience choice, but as a rule we have to, yes, we will have the audience winners also. Okay, yes madam. Because she is very sure that the judges might have not picked them up. That's why they are telling that. Shubhra madam very intelligently said that.
So the runners-up for the best team overall is the team from Warangal. And the winners of the best team overall for OPL 2023 at the conference is the Nizamabad Nawabs. Can I have the captain and the team to receive the award?
So we'll respect the audience vote. So the best overall video, according to the audience, goes to Hyderabad Hustlers. Best team, Hyderabad Hustlers. Thank you. And the audience choice, best runner-up goes to Karimnagar Kings, the runner-up.
I would like to thank my mother, father, my 5th standard teacher.
I think the two anchors deserve a huge round of applause. 3 cheers for them. Hip hip hooray! Hip hip hooray! Hip hip hooray!
Thank you, Dr. Rishi, for believing in us, and hope we had a good fun.
Yes,
and a
yes.
good
And threatening us to do this.
Yeah, kind of. I use my personal influence on them. I would request our president to just give them a plaque of appreciation for conducting the OPL so well. Take a group photograph for all the teams, please, with the judges. stay in your seats. We have a quick valedictory function where we will be announcing the results of the competitive sessions also, and we'll just have a quick thank you, and then all of us can go for lunch. I request the Secretary, Dr. Rajalingam, to take over.
Hello. Good afternoon, everybody. This is the valedictory function start. I request the President of Telangana Ophthalmic Society, Dr. Badrinarana, please come over the dais. Class Vice President, Dr. Vijay Kumar. Class Treasurer, Dr. Ravi Kumar. And I request the HOA President, Dr. Nandakishore, please come over the dais. LOC Chairman, Dr. Madhukar Reddy, please come over the dais. And LOC Organizing Secretary, Dr. Raman, Co-Organizing Secretary, Dr. Suparna, and Treasurer, LOC, Dr. Alpa. President-elect Dr. Bharat Kumar. And the Scientific Committee Chairman, Dr. Rishi Swaroop. please, Naraksha sir. I already told you. ARC Chairman Dr. Modini, please come out the dais. So, this 8th annual conference of Telangana Film Society is almost went well, and it has a very good gathering. More than 1250 registrations are there, and this time you can see the abstracts also. There are more than 500 abstracts we have received, and it's very good response from the delegates, and the trade participation is also excellent this time. And the scientific content, Dr. Rishi Swarup, the chairman scientific committee, has did very excellent work, and many of the delegates participated in national and international is there. I request our president, please give your message.
Jatra, you know, as we have enjoyed the festival of 8th Telangana Ophthalmology Conference. Dignitaries of the dais and my colleagues, friends. So regarding the conference, you can speak better than me. Wonderfully planned, wonderfully executed, each from the minute points to the selection of the topics and the designing of the programs. Excellent, everything excellently done. And firstly, we have to congratulate Dr. Rishi. Within a short time, he has taken the task and as a challenge he has taken, and wonderfully done. Excellently, very excellently done. We feel that it is about teaching months plan like that we have done excellently, and that is a very tough job as the abstracts so many. He has to read each abstract before selecting and design the thing and contact with the speakers. And another problem is what we got is simultaneously IIRC also occurring in Chennai. So there are some faculty people are there already there. They are given there. So in this short span of time also, Rishi has done excellent work. Each second is calculated and everything went on smooth. There is no small hitch in the presentations and all. And another is already, you know, the organizing secretary and co-organizing secretary, Raman and Suparna did excellent job. And all the committees like you see, transport committee, accommodation committee, cultural committee, everybody, all are in behind scene, but everything is went on well. And in finding the accommodation, everything is done well. Thank you, sir.
I request the chairman scientific committee, please announce the result.
Thank you everyone, and it's good to have a good number of people sitting in the valedictory also. I'm sure some of you are waiting to hear the results. We had all the competitive sessions went very well with very good participation and a lot of abstracts submitted. Over 556 abstracts were submitted this time, and we had a moment task of screening through them and putting them into the finals. And out of those finalists, the results are as follows. The NS Ready Postgraduate 3-paper session. The second runner-up is Dr. Parth Palan. The first runner-up, Dr. Pragya Bhattacharjee. And the winner is Dr. Devika Saxena. For the Ramchandra Reddy, P. Ramchandra free paper session, the second runner-up, Dr. Zaraf Shan. First runner-up, Dr. Charuta Puranik. And the winner is Dr. Akhila Kutumbakam. Ramana Rao Grand Rounds, the second runner-up, Dr. Pravalika Rebala. First runner-up, Dr. Renuka. And the winner is Dr. Maria Doctor. For the Swaroop video session, the second runner-up was Dr. Taranam Mansoori. The first runner-up was Dr. Raman. And the winner was Dr. Atul Gujarati. Poster, the first runner-up was Dr. Akash Pelenje. And the winner is Dr. Charuta Puranik. The quiz winners, the runner-up team was Team Trezoyance, Dr. Nandini and Dr. Anada Nambiar. And the winners were Team Rahul Rangers. What Rangers were they? I'll tell. The runner-up team was from Sarojini Devi Eye Institute, and the winners also from Sarojini Devi Eye Institute. Rahul Gogineni, Arun Kumar, and G. Pradeep. So congratulations to all the winners. And I think we have the quiz trophies here. The quiz trophies, I request the quiz masters, Dr. Rashmin Gandhi and Akshay Nair, to come on stage and hand over the quiz trophies. They were not available at the time of the quiz. Are the quiz winners here? We request the first runner-up team to come up on stage. Winners, Dr. Rahul Gogineni, Dr. Arun Kumar, and Dr. G. Pradeep. Thank you, everyone.
I request HOA President Dr. Nandakishore, please give your message.
Good afternoon, everybody. Finally, we have come to the conclusion, and it's time for us to acknowledge the tremendous hard work being put in by all the parties concerned. You know, whenever a conference is planned by the district chapter appoints a local organizing committee, And the basic idea in appointing a local organizing committee is to identify persons who, apart from their scientific knowledge and expertise, are also good at organizing things. And we need such people for the future of our society, the society to be vibrant, to continue on a very strong note and become stronger and stronger. So that's the basic idea. And when the conference was allotted to the district chapter HOA, the HOA executives sat together and thought who are the persons whom we can depend on. So our first choice for organizing secretary was Dr. Raman. Then we have seen that whenever we go to some event at Sarojini, the omnipresent person there is Suparna. So we thought she'll be very good as a joint organizing secretary. And I had the working experience with Sai Kiranmai and Alpa, so they worked extremely well during the 2016 conference. So I thought we'll include them. Then Sridhar, Arjun, Hussain, these are people who never say no. So I thought, why not give a try and have these people. I discussed with the HOA executive and they all agreed with our idea, and then that's the LOC was formed. Then we decided who should be the wise people who should be guiding these youngsters, and we thought there could be nobody better than Madhukar and Rajalingam to guide them right through. And believe me, at no point of time I had or the HO had any cause to regret the choice we made. This LOC probably is the best LOC till date with whom I have been associated, and I am sure the entire HOA executive agrees with me. There are no words to describe the amount of hard work which they have put in. I made one point clear to them that myself and Manoj are ever available to them for any suggestions and advice. And even though Manoj is now so busy with his national commitments, as always, his first commitment is to TOC, and he has always helped the LOC. As far as I am concerned, I made it very clear to Suparna. I know how busy Raman is, so it will be difficult for him to interact. One more person who always was asking me, sir, give me some role. The enthusiasm which she expressed, Charuta, I am honestly telling you, in spite of all your scientific achievements, the amount of interest you have shown in immersing yourself into the LLC activities is phenomenal. And we are very, very happy for you. So, Dr. Rajalingam, my appeal to you is, look at these people and not only these people, all the people who worked for the earlier conferences like Warangal and all, identify the people. I think we as the seniors of this society, I think the onus is on all of us to identify good people, see that we get them into the main fold, and there you have a team which is going to take you through the next decade. So I think we have succeeded in that. I'm very, very happy. At no point of time, many times Suparna said, sorry sir, we are disturbing you. But honestly, Suparna, I never felt that you are disturbing me. I was very happy that you could find time to ask us in what way we can help. And I really do hope that I have been of some help to you people. And forgive me if I have hurt any of you at any time. I have also learnt a few things when I asked, when you people allotted the faculty and accommodation to Arjun. I never got the idea which Arjun got this time. The rooms he managed so well, the allotment of the rooms. It's really phenomenal. Sridhar has been here, Kiranmai has been here all through during the inauguration. Everything went picture perfect, and I'm really grateful to the LOC, especially to Raman, who has been very, very patient with all my uh, shortcomings, and he has always stood very cool, and then it's been a phenomenal experience for me as well as my entire HOA to go through this process of conducting the 8th conference. Thank you all very much.
Thank you, sir. Organizing Secretary of Local Organizing Committee, Dr. Raman. Say a few words. Come.
Good afternoon, everybody. Actually, yesterday also I spoke on the vote of thanks. So probably this is a repetition, but anyway, I had a great experience working and interacting with all senior task office bearers and the senior friends like Nandakishore sir and Rajlingam sir and all other executive committee members and LOC members, especially with Suparna, Charuta, and then Kiranmai, Sridhar, and then Arjun. Everybody worked very, very hard. Hussein, everybody. Probably I think I gave a lot of tough time for them because many times, number of times we had the morning hours LOC meetings. Almost every alternate week, 7:30, we used to. Huh? Yeah, sometimes subsequently every week. So a lot of trouble was given to you. And another thing is Madhukar Reddy sir. Madhukar Reddy sir is really a great disciplinarian. And whenever I had any trouble or anything, any tough decision to take, so easily he used to come out with is a troubleshooter. And I'm very happy going through this journey. And I met a lot of national speakers and great eminent ophthalmologists from various specialties. And I learned a lot how to handle the situation, how to overcome the stress, and how to plan it. So it's all the inspiration from Dr. Rajlingam sir. And Varandal, again, it's a vote of thanks like thing, but I'm repeating. So if any lapses from our side, kindly forgive us. And I hope this conference is going to be, I mean, like a modular, whatever it is you think, it should stand like that. And I am very happy that our PGs, they have achieved a lot. And especially Charuta, in spite of having a lot of work, she involved in both LOC and scientific committee work, but she backed 2 prizes. That is a great thing. Really, I appreciate that. And I am very happy our Sarojini students have backed the quiz prizes, and then the paper, first and second 2 prizes, and then best student award prize, so many. And I'm very happy. I don't know actually. I stood up as a runner-up for Swaroop video session. I just overheard, but now Rishi has announced it. So I hope, I think I will continue with that work. Whatever the work I do in Sarojini, it is all the from Sarojini, our mother institute, our alma mater. So I work for my alma mater. So I assure it for the rest of 8 years till I retire. Definitely I will going to dedicate my service to Sarojini. And I am very thankful to Suparna once again. So I advise all the youngsters to learn from Suparna, how to do accounting and billing, writing, documentation, everything. So because I was very busy in other activities, but at any point of time, she never omitted anything. So once again, I am thankful to you, Suparna. And I am very thankful to my family members. So today I am little bit free actually. So I am able to speak. So my wife, my better half, Dr. Lata, and my son Karthik, and my daughter Krishnapriya. And I thank everybody. With this, I conclude.
Thank you, Raman. I request LOC Chairman, Dr. Madhukar Reddy.
Hello, good afternoon. For me, usually I used to attend conferences, enjoy the scientific part and the social part, and I never knew so much effort goes into organizing a conference until I got involved for the first time in the organizing part of it. And thank you, Nandu, for pushing me in. And this was like working with family, all of you, Sai Kiran, Sridhar, Charuta, Hussein, and Alpa, Suparna, and Raman are the pillars. Nandu Bhai and Manoj helped us, Somasila, everybody chipped in, Rishi. So I think it was wonderful organizing this conference, and we enjoyed the conference very much, and it's a grand affair. Thank you, everybody, and thank you, TOS. Thank you, TOS and HOA for believing in the LOC.
Yeah. Now we will felicitate the LOC members, sir. Please stand. I request Dr. Nandakishore, sir, felicitate Dr. Madhukar Reddy. Next, General Secretary, LOC, Co-Organizing Chairman. Dr. Suparna. Alpa. Dr. Charuta. Dr. Sridhar. Sai Kiran, Dr. Arjun, Dr. Hussein, Hussein, if anybody wants to give some message about this LOC, please come out.
members and 5 office bearers. And then that really made the team work very cohesively, and the right people were identified by Nandu, and then they all did the job very meticulously. Suparna, I would say I am seeing her mentor sitting here. Lift up the Kalanidhi, my mentor, used to say, India is better heard than seen. And now when I go to SD, I hear Suparna better than I see. Suparna has really inherited the mantle of Dr. Vidya. I also like to say. In the community, I very good. So, yeah. All the upcoming youngsters who are, I won't take the names of all the members, yes, Rama, Suparna, and Alpa. Like Alpa was a fine during the last time we did the conference, we found Alpa to be the candidate that we are encouraging everyone to come in the society. At that time, Rajesh Agarwal, Alpa, and Sai Kiran Bhai, Sai Holy Bro, I call him Ravi, gave him the dialogue bro. So I like it so much that whenever I see Ravi and I call him Ravi. Charuta is a friend of this conference, I must say. You know, Zain I know him from long, my colleague, and he's a very quiet, simple worker. Whatever time he can give for the society, he does, and he does his job very meticulously. Like the 4th and the 5th member, Sai was there, and then whom am I missing? The 5th one, Arjun. Arjun is also a find of this conference. Right from the beginning, yeah, like I had the opportunity when we were going for campaigning to all the districts. Arjun invited us to Nalgonda, and on the way he drove the car up to Nalgonda. So we had Arjun and Navakishore was there. So we had a elaborate discussion, and we gave him so many tips, and then these 5 people, I want them to come up through HOA. Most probably, Raja was always behind them, and all's well that ends well. This is a very successful conference. Only point of concern is like it's so difficult to replicate this kind of an event every now and then. Very confident that the LOC has collected this year the amount which will be revealed in the official committee meeting, but it is a phenomenal amount. At the same time, I will say that the expenditure is also phenomenal. Yeah, I will be very happy if we end with a positive balance, and I am confident that we are probably going to be all the best, and wish you all the best. God bless you to the others.
Thank you, sir. Thank you. Before going for the vote of thanks, I request Suparna to give a message. Complete the vote of
No, in HOA, all these years we have been conducting the Vista conference. So I used to deal with the trade, and somehow the trade has always been very close to me. So Mallika gave me Raman and Super. They have managed to go far, far ahead of me in trying to mobilize the train. Very happy that this is a very good sign for TOS, especially whenever you conduct a conference in Hyderabad. And I'm sure with you two being there, TOS will always have a surplus. Thank you.
So I'm an addition, it's not in the list. As Dr. Vidya is my mentor, I can't keep my mouth shut, so I have to say some words. So I won't keep you away from your lunch for a long time, but thank you Dr. Nandkishore sir and Dr. Manoj Mathur sir and Dr. Rajlingam sir for giving me this opportunity. It has really been a very, very good experience, and in this process I have made so many new friends. Charuta, Alpa, Arjun, Hussain, Kiranmai, I have worked closely with them, and I got a very new group of friends and a very good group. So whatever happens to the LOC, I don't know, but we are going to be friends forever. That's true. The nighttime discussions, the nighttime tea in room, it was really a good experience. And I would just say one word for everyone, which will describe like what comes out from my heart, because I haven't prepared anything. So Dr. Nandkishore sir, a very good advisor. I have eaten half his head. Daily, sir will call, I will call, I don't know, whatever time, small doubt, I will call. Then Dr. Manoj Mathur also I called 1 or 2 times. Though sir tried to sit on the back, but we never allowed him to. We gave the all medals, orations, everything list to sir, only for getting it done. Dr. Rajlingam, decision maker, 100%. 1 minute, clearly sir will decide this is to be done, not to be done. So people will be in confusion, but he'll clear in a minute. So very to the point, good decision maker, always a big support. And it's because of sir only that today we entered Telangana Ophthalmic Society. That is only because of sir. So, and about Dr. Madhukar Reddy sir, very disciplined. 8 o'clock meeting means he will be there 5 minutes before 8 and we'll be reaching at 8:10. So we feel embarrassed, and from the next time we'll try to come early. So very disciplined, down to earth. I never thought, because he is such a big practitioner, I never thought he is such down to earth. Very nice person, very comfortable to work with, and he is also gives quite reasonable advices. So he did the cost cutting. Dr. Badri Narayan, very down to earth sir. I am happy to be introduced to you. Dr. Raman, great. He's means I got recently introduced, no, but I had a nice time. And Dr. Raman is totally dedicated. Night 2 o'clock also he'll wake up and he'll make list. From I don't know how many months, his mind is only into the conference, and sir said today he's free. But you are not free sir. Once sir will go today home, he will see the music, because from 4 months he's not able to give time to madam and the children, they are complaining. So today that will start. Dr. Nandkishore sir, I told good advisor, thanks for all your support sir, to all of us. Dr. Manoj Mathur tried to sit on the back, but we made you the backbone. So just with these few words, and the LOC I already told, Arjun is like always on the toes, everything ready, messages to the national speakers, everything on time, hotel room arrangements perfect. Charuta very hard working, she despite of her busy practice, she devoted so much of time. Kiranmai, easy going, happy to go. I learned that attitude from her, she really enjoyed everything doing that. Dr. Sridhar, I know from long, he is into like very fine things, like meticulous, small details he will plan. Means our thought is like we should finish the work somehow, but he is into meticulous planning. So that is Dr. Sridhar's character. He'll say no, it should be done like this. So, and Hussain is a silent killer. He'll keep silent, but he'll do the work. So everyone, and Alpa, I think we exchanged thousands of messages I was sending her all the trade details and she was making the invoices. She stays silent but works very hard. So I'm very happy that I was given the opportunity and I made very good friends. That is the best advantage I had. Thank you so much, everyone.
I request the TOS Joint Secretary, Dr. Praveen, to give vote of thanks. Will event managers, Mr. Madan Murthy, or any representative. For your excellent work, please accept our token of appreciation certificate. So next we will go for the lunch.
Audio 7 person from Audio 7, some representative. Bashir or somebody, Srikanth. All LOC members, please come for a photograph. All LOC members, please come for one photograph.